lecture on basics of hysteroscopy first. So there will be a 20 minutes lecture. Till then the OT will be ready. Before that we have one cesarean section. If anyone wants to watch that also, they're most welcome to join and assist or anything. Any questions or any queries you can ask in between your lectures, in between case presentation, and if you are hesitant, you tell me, I'll ask. So that's not a big issue. And anything else you want to know about today? So I would invite team boards to give a few, what are you going to say, instruments. So they'll give you an overview of the hysteroscopic instruments.
Good morning, everybody, and thank you, Dr. Niharika. I welcome you all on behalf of Hager and Bors. Bors is manufacturing colposcopes and CTG. Hager is specialist in laparoscopy and hysteroscopy. So first of all, to thank Dr. Narendra sir, Niharika ji, Rainbow की team पूरे जो हैं कि Osama sir is coming after 3 years और sir ने जो है यहाँ पे उनका program कराया because COVID everything was stuck. Now the life is coming in the routine way, and I hope we have to live with this as well. So thank you everybody, especially Dr. Niharika madam, who is always a source of inspiration for everything, work, fitness, energy. Although I was asking yesterday with sir, there was one conference, sir, what is the secret behind your fitness and always smiling? कहते कुछ नहीं, बस सबको relax रहो, means like this. And anyway, so I am Arvind Bindal. I am the director of the company. We all are here to learn or excel our skills in hysteroscopy. Few doctors would be doing hysteroscopy. Some would be doing vaginal, means diagnostic hysteroscopy. Some would be operative, and some want to start the hysteroscopy. So the important part is instrumentation. If I want to drive a car, I should know my car very well. If I'm going on the highway, that I should know what is the speed, braking should be good, and is the weather is. So that is very, very, believe me, if 100 doctors have purchased already the system hysteroscope, but very few are using it, because there are 2-3 things. First is, we generally follow I am an engineer. In doctors, we follow our friends, gurus, or means seniors. So वो जो recommend करते हैं हम लोग लेते हैं. That is good. But the only thing is, it is not a rocket science. We have to understand this is not a rocket science. It is very, very simple. Simple is that the size of the instrument earlier was 4 mm scopes, and if we make all the assembly, it becomes 9 mm. And internal cervical os is 4 to 5 mm. So we used to dilate. Anyway, sir, Osama sir will come, Dr. Narendra will be there, and you can ask n number of questions, whatever you want. But I want to cover that the instrumentation part. So I want to welcome you on behalf of Hager Germany as well. Technical elaboration of hysteroscopy instruments, past, present, and future. We all know this is endovision camera, monitor, light source, fiber optic cable, hysteroscope, intrauterine fluid management system, that is hystojet, and instrumentation. We very well know there were 2 kind of technologies in camera. Earlier it was chip technology. हम लोग बोलते थे single chip camera या 3 chip camera. But now everything has come to the HD or full HD, and the technology is CMOS. Chip was there was a CCD camera, that is the charge coupled device, and CMOS is complementary metal oxide semiconductor, full name, but we used to say CMOS camera, 1 CMOS or 3 CMOS, and the latest is a 4K. We should only remember one thing, that whenever we are going for any camera, the DVI output is the real thing. Because if you go to buy a TV, that will be very interesting for you. TV person will tell you, salesman, madam, this is HD ready, semi HD. There is nothing semi HD, HD ready. There are only 2 resolutions, 1080 and 1920. So we should always look for the DVI output. Medical grade monitor is very, very important. When we are going for 3 CMOS camera, we should go for the medical grade monitor. Light source, LED is the latest, effective value for money, and running cost is very low. Fiber optic cable is very, very important, because fiber optic cable we cannot kink. There are 3 kind of fiber optic cable. Jelly filled, there was a jelly inside. If galti se puncture ho jaye to jelly bahar aa jati hai, bekar ho jata hai. Glass fiber you cannot kink. And the latest is Ribbon fiber. Ribbon fiber means because when you go for fiber optic cable, you don't need to spend money all the time. We can, means the durability is very well. Once you will buy a cable, then whole life it will work with you. Same is the light source LED. We have LED lights. The recommended lamp life is 60,000 hours. If you daily do 3-hour surgery, 300 working days, 300 into 3 is 900 hours. Let us count 1,000 for a year. 60 years it will work. And okay. Now the hysteroscope instrument. 4 mm 30 degree and 2.9 mm 30 degree. 4 mm hysteroscope is common, but operating sheath, inner sheath, as I told you, if we put, becomes 9 mm and it is difficult to go inside. Important thing is we have to remember one thing. Whenever we buy any hysteroscope, it should have separate instrument channel and separate channel for fluid, which gives continuous flow during operative process. What is the problem? Look at this. This is inflow of the water. When I am doing, means you are doing diagnostic, then there is a space for water to go. This is instrument channel. When I put instrument for operative, this is the instrument, okay? Instrument channel, and this is the water channel. This is same in all the sheets available in the world, but only we have a sheet which have a separate inflow and separate instrument channel. Because what happens if I put the instrument, then this is the same 5 French is the diameter of the instrument channel, and the 5 French is the dia of the instrument. So there is no space for the water to go inside. So it should always have a separate channels for the water for the instruments. And what happens, you see, we have done more than 10,000 cases, Dr. Shawki. We have never do a dilatation, because anything happens, remove this and the size will become 3.5 mm. And once you go inside, and then we can put the sheath again and put the complete assembly into the cervix. This is the instrumentation, scope, sheaths and instruments. How to assemble it is very, very important. This is correct. Turn the lever 20 clockwise. Take the scope. The light cable should be up. Put the scope into this. Light cable should be up. Light cable should be up. Fix it and then lock. Thank you. What happens when we are doing like this? Remember, this is the lever. As I told you, this is the lever. Anti-clockwise, come out. And once it is locked, it cannot come out. You see? But what happens? Sometimes you get a call, and you will see here as well. I don't know kaise khul gaya, maine to lock kiya tha. No, this is what happens is when we are using like this, then we touch this lever and we don't know. And if we touch this lever, the scope will come out. So there are endotainers. I request to everybody, whenever you go to OT, before going OT, we should have a feel of the instrument so that we will do better. Okay. This is very, very important. The size is, the scope size is 2.9 mm and the viewing angle is 30 degree. What is the meaning of the 30 degree? 30 degree means if the light is down, it will show the picture opposite to the light cable. This is the cable, light cable. It will show picture like this. Okay, 30 degree means it will show the picture at the angle of 30 degree. 0 degree we use laparoscope. That means 0 degree, it will show the picture like this. 30 degree laparoscope will show like this. If the cable is this side, it will show picture like this. Cable is up, it will show posterior. And the cable is left side, it will show like this. This is very, very important. 3 points. Next slide is very important. That connect the fiber optic cable from the below. Professor Shawki used to say, sun rises from the below and the rain comes from the top. So light is the below and this is the top. Believe me, 99% doctors are doing like this, which is wrong, because when we go inside, we see posterior instead of anterior. This is urologist. Urology people use it. Sun rises from below and the rain comes from the top. Connect fluid tube from the above. Camera coupler should not move, because you see camera, when we move the camera coupler, picture changes. We will show you there. Rotate the fiber optic cable to visualize the tubal openings. As I told you, this is very important. Do not touch the lever of the sheath, otherwise hysteroscope may open. Fiber optic cable connection should be below and fluid connection should be upwards. We should never see internal cervical loss. Anytime during insertion, look for the crescent view. What is my experience? I have seen most of the time we are struggling to go inside. If the total duration of the operation is 20 minutes, we take 15 minutes to go inside and 5 for the operation procedure. But the thumb rule is we should look for the crescent view, half moon view. We have to understand our eyes will think that we are not able to see anything. But look for the crescent view, which I will show you in the videos. Camera should not move. It should be like this. The switches should be on the upper side. Hold the camera with the left hand and turn the cable like this. Then down and then left. Remember one thing, the light, the sun comes from below, so light comes from below, and the rain comes from the top, so the fluid should come from the top. Don't forget, this is the exact position to hold. Your hand should be like this. Left hand should be camera and right hand turn the cable. Don't touch this lever. Don't touch this lever, otherwise the scope will be open. Thank you. Generally, what happens when we are not used to, we try to hold everything in a one go. We try to hold camera as well as and the scope as well. Look at my hands. This is the best way. Most of the time, we try to hold till this. That scope khul na jaye like this. Once, as I told you, once the scope is like this, it will not open. And when the total camera coupler, it will not open. So remember this view. This is the correct view to hold. Then you can do, and your one hand should be free so that we can put the instrumentation. And so 2 hands we have to use. Most of the time we try to hold like this. Okay. And you see my finger will come here. Remember, if it is fixed, it will never go. It will not come out from this. So we have to hold like this, and then put the instruments. Left or right, whatever you feel comfortable. Because when we try to do something, I am righty, so it is comfortable for me to use the instrument with the right hand. Whatever you want to do is never hold like this. Okay. This tension is very, very important. It maintains constant preset intrauterine pressure and ensures good dilatation of uterine cavity with a clear view during hysteroscopic procedures. It is very, very important. You see, we are using saline inside or glycine, that is a liquid. For an example, if I take 1 glass of water and put a drop of ink, everything will become blue. Same if there is a 1 drop of blood inside, everything will become red, and we are unable to see the clear view. We will only see red color. Okay, so good viewing condition allows the surgeons to work efficiently and thereby reduce the surgery time by 50%. The pressure also helps to prevent bleeding inside the uterine cavity, and chances of false passage is minimum. The power of water will do everything by itself. Once we press the labia, the vagina is ballooned and we can do vaginoscopy as well. And the power of pressure opens the internal cervical os automatically. How to enter now, I will show you. This is vaginoscopy. This is correct view. I will show you again. This is crescent view. We should look for this. We have to remember this picture. Look at the distension. Never look for posterior. Always look for anterior. 30 seconds we will be in. we are in 30 seconds. This is the exact view. See how much time it took? Less than 30 seconds. This is vaginoscopy. And let us see the reality. What is the reality? Generally, we see this kind of picture, as I told you, the flag of Japan. How we will work if we will able to see like this? Most of the time we see blur view, tight space, no working space. We require working space so that we can work. Low quality view means more operating time and lower success rate. This tension is very, very important. Please remember. When we are cutting, no bleeding because the pressure is above 120. Mean arterial pressure is 100. And if we keep the pressure more than 100, there will be or less bleeding. This is correct. This is wrong. We should never say this. This view is wrong. This is correct. And what will happen when we reduce the pressure? If the equipment machine is showing pressure of 150, doesn't mean it is 150. That is the pressure of machine. When it will go to the cavity, it will be reduced. No bleeding because the pressure is 100. And this is because of Shawki histrojet. This is very, very important. It's like this. If we do laparoscopy, generally what do we do in hysteroscopy? We use the pressure bag. For an example, let us assume we have no insufflator. I have never seen a surgeon who is doing laparoscopy without insufflator. Or you must have also not seen anybody, but it is in hysteroscopy. We do hysteroscopy without this device. For an example, let us assume I tell my OT assistant, open the cylinder. As soon as I achieve the neoperitoneum, close it. And then there is a suction, open it again. So can I do laparoscopy in a good way? No. So this is very, very important if we want to excel our skills. So this is very, very important. And it is absolutely true because doctors white, they were not buying because most of the companies were selling for 10 to 12 lakh rupees. तो हम लोग हमेशा सोचते हैं कि कैमरा शुड बी गुड, बाकी चीजें हम लोग ले लेंगे ऐसे करके, बट वी आर द ओनली कंपनी व्हिच हैव रिड्यूस्ड द प्राइस टू द वेरी लो. It is fully automatic, just press power button and it will maintain selected preset pressure all the time. How it works? Shawki project. First switch it on by pressing the button and then put the cable. Remember, this is round, this is flat. Round should be on the back side. Put the tube first, and then fix it. Now it should be, surface should be absolutely plain. Take the tube, pull it till it is fixed here, right? The another part of the tube should be in the automatic sensor. So it is connected. There is a facility that you can connect 2 bottles, 3 liter, 3 liter. So this is the bottle, 3 liter, 3 liter. And now you just fix the pressure. Suppose you want to. Why 3 liter? Generally, we are using 1 liter bottle regularly, because what happens when we have a bottle and starting or doing, so we have to change the bottles most of the time. So it is better we have a bigger size of bottles. Preset pressure, 200 mm of Hg. And then press start stop. That's all. It is ready. Once again, I want to tell you, switch it on. Set. The important part is we are getting a lot of calls from doctors कि pressure जो है वो cavity is not maintaining, because the reason is this is the flow rate. What happens most of the time, the flow rate is the maximum is 1 liter. They reduce it to the OT staff to 0.2 liter or 0.5 liter. The flow should not be high. Please remember, 1 liter means it will automatically decide whether it requires 1 liter to give or 0.1 or 0.2, depend upon the pressure of the cavity. So we should have always keep this on 1 liter. Okay. Look at this. This is very, very important case. And I want to show you the power of water. Hydrodissection, no instrumentation. Can you able to see? This is very, very important. So wait, millimeter by millimeter, we have to wait, and when we are inside. Operative instruments are very, very important. Caesar, we can do maximum work with the Caesar, arched uterus, polyp, septum. Remember one thing, Caesar. In laparoscopy, we do hands, okay? But here we cannot do. Look at this. If I am moving the instrument left, right, can you see instrument is moving? No. Okay. So if I have to go, this is the polyp, I have to go to the polyp. So I cannot move my Caesar. I have to move complete assembly. So we do like this, nothing will happen. Your instrument will be broken, and then you have to pay 30,000 rupees to us, to any company. So my request is, because there is no guarantee for these semi-rigid instruments. Okay. So we can only use this, we can turn. If you see the jaw of the Caesar, I can only change the jaw left to right. I cannot move my instrument up, down. I have to move complete assembly. So please remember these things. This is very, very important. So lot of time doctors ask, if we have a laparoscopy, then how we want to, what we require. So only the requirement is 2.9 mm sheath scope assembly, jet, and the instrumentations. If we do not have laparoscopy system and we want to start, so this is a compact hysteroscope, less, the price is comparatively economical and easy to carry. So it have a compact hysteroscopy solution, have everything, camera, small light source, and hysteroscope, hystropump, and then instrumentation. This is the system in the back. This is the small source camera. It can work, the camera and light source will work in laparoscopy as well for the basic system. What it includes? It includes 2.9 mm 30-degree scope, hysteroscopy sheath, camera, LED, light source, fiber optic cable, and software for patient recording, which is very, very important, because we can give color reports to the patient, and seeing is believing. For an example, I have seen a lot of doctors call the attendant of the patient when do sonography. Why? To show ये baby है. उनको कुछ समझ में नहीं आता patient को, उसको लगता है there is a black and white curtain, but it is found seeing is believing. Patient बोलता है doctors take a lot of time to understand patient ko kya samajh mein aayega, but seeing is believing. So when we give color reports, so it is easy for the patient to understand kam blood hai, kam kharab hai, zyada blood hai, zyada kharab hai, blood nahi hai to theek hai. Because the lady, प्लीज अंडरस्टैंड, हम लोग मैंने देखा डॉक्टर्स बनाते हैं कि दिस इज द डिजाइन, ये लिखा होता है ऐसा है, पर पेशेंट ने कभी देखा नहीं कैसा सर्विक्स है. सो पेशेंट विल कम एंड गो टू द होम. इफ यू एक्सप्लेन 100%, शी विल अंडरस्टैंड 70% बिकॉज सब मेडिकल टर्मिनोलॉजी इज इन्वॉल्व. घर जाएगी, हस्बैंड को बताएगी, शी विल अंडरस्टैंड 50%. हस्बैंड विल टेल टू द पेरेंट्स 25%. हु इज डिसीजन मेकर? पेरेंट्स. और डॉक्टर साहब का तो काम ही उनका कहना होता है. सो इन व्हेन वी हैव कलर रिपोर्ट्स, 100% to the patient, 100% to the husband, 100% to the parents. It is easy for you comparatively to convince the patient according to the line of treatment. It can be handled by one person, one woman army, easy to use, easy to operate, easy to assemble, very lightweight, as I told you. Patient understand 100% due to color reporting and its software. This is resectoscope, bipolar resectoscope. We have earlier 4 mm resectoscopes, that is a monopolar. So now bipolar resectoscope have come. Why resectoscope were not popular? Stectomy हो जाती थी, कुछ भी था, because 4 mm hysteroscope is used and the size becomes 10 mm. Lot of dilatation was required using glycine, safety concern. Glycine, जैसी glycine आता, no. Chances of complications are more, long learning curve, and monopolar cautery is used, which is less effective. Lot of worries and generally poor result. Satisfaction not guaranteed. But now, instead of no to glycine, play safe. We don't want to use glycine. The only thing is we will use the saline because it is saline friendly, no complications, and bipolar cautery is much effective. No worries, optimum result, satisfaction guaranteed. But remember one thing, when we will ask any senior or some person, they will say this instrument is not good. But remember, there are two things. One is energy source and one is the resectoscope. Most of the time we have a cautery ESU, electrical surgical unit, which have 2 facilities, monopolar, assemble kar do, monopolar and bipolar. Am I right? Monopolar have 2 facilities, cut and coagulation, but bipolar have only coagulation. So when we use same cautery with bipolar, when we use 4 mm monopolar, when we press cut, it cuts. When we press coagulation, it coagulates. But when we use same cautery for resectoscope bipolar, the bipolar cautery have only coagulation. So when we press cut, it only do coagulation. When we press coagulation, so we should always buy a cautery when we go for resectoscope, or if you are buying a cautery for keep the future in the mind, we should always go for bipolar cut and coagulation. So bipolar cut and coagulation, this is resectoscope, and we are the only company we have resectoscope which can work monopolar and bipolar both. Okay, so look at the size. This is the monopolar. The size difference is only 25%. For an example, if I take 20 minutes for resectoscopy, if the size is smaller, it will take 20 minutes more, 25% more. 20 minutes ka 25% to 5 minutes. Instead of 20 minutes, I will take 25 minutes. But remember one thing, that time can be covered by the bipolar cautery, because bipolar cautery is much more effective, less tearing, tissue, no tissue sticking. So we should always go for bipolar resectoscope, and cautery should be equal to the fit to this resectoscope bipolar cut. So remember, if we provide Sachin Tendulkar this kind of bat, what will happen? Any bowler can clean bowled him, okay? But T is very important. Latest technology, equipments, proper technique, effective training, correct training, try and try again, try and try again. We can hit 6 on these balls as well. So thank you very much for your patient listening. This manual is designed by us with the experience of Professor Shawki. I request you, please write your name, because when you go back, it looks same. And please go. There are a lot of myths. You will check it. I guarantee you, once you will go with this, you will have a very short learning curve. Once you come here, Shawki used to come. They used to say, whatever you learn, keep it in the trash. Fresh start. and I am sure a lot of people will see what is the difference, and everything will be just opposite what we are thinking. Any questions? Scope is 2.9 mm, and if we remove the, ma'am वो recording हो रहा है, सबको पता चल जाएगा questions. And it is,
Diameter
see,
of the inner
the size of scope is 2.9 mm. If we put both the sheaths, inner sheath, outer sheath, the size is 4.8 mm. It is oval shape. Why doctors were confused? There were three problems, which is already written. Office hysteroscope confused doctors a lot. Office means OPD, right? Generally, what happens, this concept is in Europe or the big hospitals where the charges of OT is very high. So office means we have to do in the OPD.
Yes.
So, okay, is it clear to you? Second office is diagnostic. Believe me, you will see when you will see the sonography, most of the time hysteroscopy is see and treat. Oh, very good. Bas, बुला लो सबको. See and treat. It is like this. जैसे ही मैं अंदर जाऊंगा, I suppose I am doctor, diagnostic है. So what I will tell to the patient, come after 1 month or 2 months when I will have in operative sheath and instrument, then I will operate. Third thing is choice of anesthesia. Office since a patient is awake. Choice of anesthesia. If resectoscopy or cautery, patient cannot be awake. So short GA, proper GA, or patient is awake, that is not an issue. So this is myth, lot of things. And I have seen a lot of conference, they used to say, I put misoprostol और तो आराम से dilate हो जाता है, कुछ नहीं होता है. It is absolutely wrong. वो भी लिखा हुआ है, because misoprostol, very nice, madam, thank you, soft not dilate the cervix. I keep pressure 40. I keep 80. No, I keep 60. I keep 40. Absolutely wrong. Please believe me, you will see. You will go in the OT, the pressure always he keeps above 150, because 150 से pressure शुरू करते हैं तो अंदर जो जाता है cavity में वो pressure drop होता है, तो it will be more than 100. So you will, and we have a HPS, hysteroscopy product specialist. They will give you the clinical support. You keep few cases, they will come और हाथ पकड़ के वो आपको बताएंगे कि कैसे कैसे. They will help you so that, because that they know, and endotrainer we will tell you, so mistakes will be less and the learning curve will be very, very short. May I know how many doctors are doing hysteroscopy? आप लोगों में से कोई कर रहे हैं अभी? Laparoscopy है किसी के पास? आपके पास है मैम? You are from which place? Sorry? Mercury. Okay. So laparoscopy कौन करता है आपके यहाँ पे? Surgeon. So you have to only go the. Yeah, thank you. You have to only take the 2.9 mm sheath scope and jet. Anybody else is using? Husband is urologist or surgeon? देखो मैम, I am in this field from 25 years. Remember two things. First of all, भले ही मैं कंपनी वालों, लेकिन हमारे मुंह पे लिखा होता है ये लेंगे, but I am your well wisher. I am doing from 25 years. Ladies are the most busiest in lady gynecologist. Hospital, IVF, IUI, colposcopy, CTG, laparoscopy, hysteroscopy, family, kids, hospital, husband, no time. For an example, अगर मुझे मीन्स आप मैं ऐसे बोल रहा हूँ, प्लीज मीन्स आई वांट टू वे कम्युनिकेशन, एम्बेसडर चलाने के लिए दे दीजिए, गाड़ी चलानी भी आती है तो क्या होगा? कोशिश होगी नहीं चलाना है, स्टीयरिंग है, और अभी गाड़ी आ गई है ऑटोमेटिक और बड़ी गाड़ी फॉर्च्यूनर दे दी जाए तो कोशिश होगा जल्दी हम सीख जाएंगे. प्लीज रिमेंबर मी, यूरोलॉजिस्ट या हॉस्पिटल में सिस्टोस्कोप यूज करें. ऑल्दो यू आर राइट, सिस्टोस्कोप और हिस्टोस्कोप 4 mm इज सेम. यूरेथ्रा में डाल दोगे सिस्टोस्कोप और अगर उसमें डाल दोगे तो हिस्टोस्कोप. बट व्हाई 2.9 mm इज पॉपुलर? ये उस तरह है कि anybody have a mobile which have a switches? कीपैड वाला मोबाइल है किसी के पास? आप में से है किसी के पास कोई यूज कर रहा है? ये उसी तरह है कि आप कीपैड वाला, ये नहीं कि कीपैड वाला मोबाइल यूज नहीं कर सकते हैं, बट स्क्रीन बड़ी है, व्हाट्सएप करना है, तो ये उसी तरह है कि हम कीपैड वाला मोबाइल यूज कर रहे हैं या वो लैंडलाइन वाला फोन यूज कर रहे हैं इंस्टेड ऑफ मोबाइल. आज की डेट में कोई नहीं कर रहा है. मुश्किल ज्यादा होगी, कर सकते हैं, आई डोंट नो, कर भी रहे होंगे आप, लेकिन वो मजा नहीं आएगा. एंड until unless we will not enjoy, we cannot do. If we are hanging, we have 10 friends, पर जिसके साथ ज्यादा एंजॉय करते हैं उसके साथ ज्यादा हैंग आउट करते हैं. तो जब तक हम एंजॉय नहीं करेंगे किसी चीज को तो हम उसे यूज को कर ही नहीं पाएंगे. दिस इज द बेसिक थिंग. रेस्ट इज मींस, और सबसे इंपॉर्टेंट क्या, कॉस्ट इज वेरी लो. फॉर एन एग्जांपल, अगर एक सिस्टम हिस्ट्रोजेट और शीथस्कोप आप लेते हैं, ऑलमोस्ट द कॉस्ट इज, फॉर एन एग्जांपल जो लेप्रोस्कोपी कर रहे हैं, 6 to 7 lakh rupees. इफ आई टेक बैंक लोन तो 25% अमाउंट आई हैव टू पे. 6 lakh का एग्जांपल लेता हूं तो 1.5 lakh, 3.5 lakh बैंक विल गिव द लोन. और मैंने 3 years के लिए भी लोन लिया तो 3,000 रुपए की किस्त आती है. 3,000 rupees इज द इंस्टॉलमेंट, और टैक्स में बेनिफिट मिलेगा. और जो लोग नहीं कर रहे हैं, शुरू करना चाहते हैं, CHS जब बताया है, टोटल कॉस्ट विल बी अराउंड 12 lakh rupees. 12 lakh में से 3 लाख मैंने अपनी पॉकेट से डालना है. 9 लाख रुपए का लोन कर लिया, 5 साल के लिए लोन किया तो 7,000 से 8,000 की EMI आती है. मिनिमम चार्जेस चैरिटी से चैरिटी भी अगर आप 10,000 भी लेते हो, एक पेशेंट किया तो ब्रेक इवन आ गया. सिर्फ आपने 3 लाख रुपए अपनी पॉकेट से लगाए. और टैक्स बेनिफिट होता है डॉक्टर्स को, किसी को, जैसे हम भी कंपनी में है, इफ यू आर बाइंग एनी इक्विपमेंट. ट्रेनिंग करके जाओगे, जल्दी भूल जाओगे यहाँ पे जो सीखोगे, क्योंकि धीरे धीरे हम लोग वो, एंड बहुत सारे मेरे डॉक्टर्स फ्रेंड्स आते हैं कॉन्फ्रेंस में, AIC हर साल आता है, नहीं अभी सोच के जाके करेंगे, इतना बिजी हो जाते हैं पता नहीं चलता कब कॉन्फ्रेंस आ गई है. सो वंस अगेन सर आ गए, थैंक यू सर, की बहुत बहुत ज्यादा है. हमेशा सर जो है सोर्स ऑफ इंस्पिरेशन रहे हैं और फिट रहते हैं. मैं जब सर ने पहली कॉन्फ्रेंस कराई थी आगरा में, AICOG, तब हाथी घुमा दी, मुझे याद है 4 में, ठीक है. अभी उसको 18 साल हो गए, फिर सर ने दोबारा कराई. तब मैं 24 साल का था, सर ऐसे ही थे. अब मैं 42 साल का हो गया हूँ, तब भी सर ऐसे ही हैं. तो ये सर का चार्म है, सर हमेशा ऐसे ही रहते हैं. और आगे अगले 20 साल में भी मैं हो जाऊंगा.
ये कलर करने लग गया, बाल मैंने नहीं करे अभी
सर
तक.
वो वाली बात है, आई वांट टू शेयर. सर ने ऐसे बोल दिया, तो एक मूवी आई थी सैफ की, तो ना वो उसकी गर्लफ्रेंड सैलून में रहती है. सर ने तो बोला, तो जाता रहता था, हमेशा कलर रहता था. तो ही वेंट टू एनी डिश, उसने पूछा, समबडी आस्क्ड व्हिच कलर यू आर यूजिंग, तो उसने बोला इट इज नेचुरल. तो मेरी वाइफ भी बोलती है क्या है, मैंने कहा आई हैव नेचुरल, क्योंकि नेवर कभी देख रहे तो इज लाइक दिस. सर जो है हमेशा फिट है. और मतलब बिलीव मी, ऐसा नहीं सर के सामने, आई हैव नेवर सीन अ पर्सन इन माय लाइफ जिसने सर के लिए कभी पॉजिटिव, मतलब कुछ पॉजिटिव ही बोलते हैं पूरी दुनिया. एनीबॉडी, वेदर इट इज डॉक्टर्स, कंपनी पर्सन, हम लोग बोलते हैं तो ये है.
So welcome to the workshop today. This is Dr. Anupam Gupta. As you know, he was the past vice president of Foxy and in all the programs in Agra also, and an IVF specialist. So Anupam will briefly tell you why such workshops are very important for this.
Thank you. First of all, welcome all of you to our city of Agra and this Ujala Cygnus Rainbow Hospital, which is not his hospital, but is the hospital of the entire doctors of Agra. And we have Dr. Osama. Welcome. I'm sure you'll be all. I'm sure you all would be welcome.
Lovely to be in Agra, in the city of one of the 8 wonders of the world, and you are the 9th wonder. Okay. Well, welcome all of you to this fantastic sightseeing tour inside the cavity of the uterus, which I call it the greatest temple in humanity. And yesterday I said something which people admire, that this temple, each of you spend 9 months, full board accommodation, pampered inside that 37-degree jacuzzi and sleeping on the soft pillow placenta. And you remember when you get out of that temple, you started to cry. First thing we do, we cry when we are outside. So I do thank very much my brother, Dr. Narendra Malhotra. And it's really from my heart. Although we live thousands of miles away, we are different culture, different language, different many things. But truly, I feel that genetically, we are very much connected to each other. So he is a visionary man, actually. And I say that skills and talents is not only in the hands. You think that this surgeon it's in the mind. The mind translated into your hand and in your words. The way you speak, the way you operate, it's come from your mind. So Dr. Malhotra had a vision that gynecology It's a science which depends on tools for diagnosis and treatment. And technology brings us every day a lot of new things. We should be very careful in choosing what's coming up. Like, for example, robotic surgery. Okay, it looks very attractive, okay? But come on, you bring me a machine with the complicated arms with the thousands of dollars cost to remove a myoma, or to, don't tell me that, all right? Harmonic scalpel, ligature, but okay. Any young, humble gynecologist in little village in India can do NDVH, all right? And the uterus is an organ which already 1/3 of it is outside the body. Why you jump and puncture the belly to remove it out? And remember that the ENT specialist, they don't cut the throat to remove the tonsils, all right? They take it from the mouth. So for example, so many new ideas coming up. Some of them are really valuable and some are just fantasies. So I do believe in the same vision with my friend Narendra that every gynecologist should master very well the two pillars for diagnosis and treatment, which are ultrasound and hysteroscopy. Vaginal surgery is the third part. This is the pillars that a gynecologist sit with the crown on his head. If you want to replicate and copy the surgeons and do 1 to 5 punctures in the belly to remove a small uterus, this is not wise, all right? So this is maybe my 10th visit. I had a presentation to show you some information, to tell you how many times I came to India. I completed 168 visits to villages, small cities, big cities all over India, completed more than 5,000 surgeries, thanks God, and trained unlimited number of doctors. So I'm very glad that you are newcomers to join me to the cavity of the uterus to see how to enter, how to see up, how to see down. Hysteroscopy, before I start, I say only 1 minute more. Hysteroscopy is totally different than laparoscopy. Starting from the axis, it doesn't require more than 5-6 times trial to push the trigger to know that you are inside the peritoneal cavity. There is no much difficulty and challenge in that. While in hysteroscopy, it's a hell to drive from the external os to the internal os into the cavity. This is not easy at all. Don't think it's a uterine sound or a dilator. Okay, it requires a lot of tactile sensation and maneuver, different than laparoscopy. And then once you're inside the belly, if I bring 10 doctors, gynecologists, who doesn't know anything about endoscopy, and they attend with me laparoscopy, and I go by the telescope and ask them, what is this, what is that? It doesn't require any effort to know that this thing in the middle is the uterus, that 2 white things are ovaries, and that swelling is a myoma, and that cyst is an endometrioma. Anybody can know this, even if he's not an expert. But if I bring the same 10 students and show them inside the uterine cavity, they will never know where is up, where is down. And this floating shred, is it a polyp or an endometrial shred? Okay, if this fundus is normal or an arcuate, it requires a lot of visits and training, and you have to stand next to somebody to show you this. I have to say, it is not easy, but it's not impossible. I give you the example of riding a bicycle or knitting needle. You see an old lady working with the knitting quickly, and she makes a piece of cloth. It looks impossible, although she's not educated, this lady. But she started slowly, and by time, it will be in your hand by default. It will be implanted in your soul and body. I see. Hysteroscopy is not like laparoscopy or surgery. Okay, once you acquire it, you can work closed eyes. It's a sensation that you catch and you will never lose. So Dr. Narendra told me that we will have a lecture first, and then they put the case to sleep. So I don't know.
Septum is ready.
All right. So, okay, uterine septum is a congenital anomaly. 1 minute orientation about septum, and it exists in almost 8 to 13% in cases of primary infertility, and up to 25% in patients with recurrent pregnancy loss. So it is a high percentage, okay, of cases suffer from uterine septum. Does it affect fertility? Definitely, it is a cause of recurrent pregnancy loss. about infertility. Some people say yes, some people say no. So if you see a patient just recently married with a septum, there are two opinions. Either give her a chance for 1 year. If she's not getting pregnant, you do the surgery, or you do the surgery immediately. So what Osama opinion? My opinion, if you're an expert in hysteroscopy, immediately have to correct it. Why? Because this lady, no doubt, she'll get pregnant. She'll get pregnant. But 80% abortion will happen. Then come the problem. Evacuation will be very difficult. Misoprostol and curettage, you don't know where you are. And then they come to me by Asherman after that because of retained product of conception. So you have to be competently skillful and go to correct the septum and give her the better chance. How we will do it? We can do it by the scissor or the resectoscope. You achieve good panoramic view, locate the septum and start exactly in the middle and move from below up and just stop when you see both tubal ostia are at the same level. Do we need to put a balloon or IUD afterwards? No, even no need to give estrogen treatment. The healthy endometrium around will grow and heal and cover the septal scar area. And after 2-3 cycles, she can go for spontaneous pregnancy or for IVF. Okay, so after surgery, you can ask more questions. And we have time. I have a nice lecture which cover all about hysteroscopy. Thank you very much. Thank you.
Good morning, everybody. So first patient to be taken for hysteroscopy would today be subseptate uterus. That her blood reports are all normal. She is married 3 years ago, had 1 abortion of 1 year back, followed by evacuation, and her LMP was 3rd July. So periods are regular, but since her report says subseptate, it should be corrected. So here we go for the first case. Thank you.
The patient is still not asleep, so we can add some more information. Diagnosis of uterine septum of congenital uterine anomaly is primarily by 3D ultrasound. Hysterography, okay, hysterography will give you the Bugs Bunny ear view, okay, the V-shape, 2 corneas. And it's sometimes very difficult to differentiate between, is it a septum or a bicornuate? Bicornuate, each cornea is separate and in between there is space there. So if you wrongly go to correct from below, you will perforate. So you have to get a concrete diagnosis before surgery that it is a septum. I never operate on a septum without a 3D ultrasound. At hysterography, if you have this Bugs Bunny ear, sometimes you can guess, is it a septum or bicornuate? If the angle between both corneals is less than 90 degrees, acute angle, is 100% septum. 100% septum. If the angle is obtuse, more than 90 degrees here, it could be broad septum, but it can be bicornuate. So you have to do 3D ultrasound and see the space between both corneals. Is it tissues, septum, or it is empty space? There are a third variety, which is the most dangerous one, which is a uterine septum with a bicornuate notch. And this is very important to diagnose before surgery, because as I was just saying, during septum correction, you keep cut until both tubal ostium at the same line. If there's a bicornuate notch, you will perforate in the middle. So a clear 3D view should be available. Timing of the procedure should be in the post-menstrual phase. So the endometrium will be thin, so your visibility is better. And also give a chance post-operative for the estrogen of the proliferative phase to help healing and build up of the endometrium. As I said, there is no need for post-operative treatment, no need for hormones, no need for anything or supplement. Patient can go for pregnancy, spontaneous or IVF after 2 to 3 cycles. And the mode of delivery can be safely vaginal delivery, no indication for cesarean section, which is totally different than the old surgery of Jones and Jones and Tompkins and Strassman, where they cut the uterus and take sutures. This is more complicated and can lead to adhesions and can requires definitely cesarean section delivery afterwards. Septum is a cause of infertility and recurrent abortion and should be corrected. Bicornuate uterus doesn't have any role, and there is no role for surgery in correction. Should we do cerclage for those women? There is a controversy. My opinion, no need. Some people do it as a prophylactic cerclage. I do believe we can give only progesterone hormonal support during pregnancy, and that will help to extend pregnancy till near term. Cerclage will not help. It will close the cervix, but it will not prevent uterine contractions. So contractions will happen and it will cut into the cerclage. There is a different opinion in that. Unicornuate uterus, also there is a controversy if there is a surgical need for a surgical correction or not. Yesterday, Delhi, I did expansion of a unicornuate uterus that you cut laterally to expand the size of the cavity. Why septum cause recurrent pregnancy loss and infertility? If you open any textbooks, you will read a lot of explanations. Some of the explanations that the septal area has defective endometrium over it, so implantation will be poor. Other explanation, which is in my opinion, sorry to say, very stupid and very naive, that because the septum divide the uterus into two smaller cavities, so the baby cannot accommodate and grow. This is very naive thinking, because the normal size uterus can accommodate for 2 and 3 babies. Am I correct? So half of the uterus can easily accommodate for 1 baby. This is not the cause. My opinion that according to the recent literature, septal tissues are basically muscular. It is not fibrous tissue as we used to teach in the past. It's very muscular, very vascular. And the arrangement of muscle fibers in the septum pulled between the anterior and posterior wall, this causes incoordinate myometrial contractility. And that's the reason for recurrent pregnancy loss. And again, it is not mid-trimesteric as we used to teach. It can happen even first trimester or early implantation failure because of the abnormal contractility, because of the incoordinate muscle arrangement in the septum. A frequent question asked to me now recently, Osama used to teach and to show that the septum surgery is just to cut, not to excise. Excision and removal of a septum was a very old concept since the time of Jones and Tompkins procedure. They do wedge excision and remove the septum, assuming that this septum is abnormal, extra tissues should be removed to restore normal care. This was the old concept. So recently, a team from Italy published an article that the septum should be excised, okay, not just excised. And this created a lot of confusion and controversy and put a question marks about all what I have been teaching, all right? I found that the best way to defend my concept and to prove my opinion, my vision, is to do surgery and cut the septum and show that the fibers retracts and there is no residual hanging fibers afterwards. Even when we decrease the intrauterine pressure and the cavity collapse like this. There is no hanging flaps of septum that they thought it had to be excised. And I did another experiment in a case of broad septum. One half of the septum, I only cut, the other half I excised according to the concept of Italian paper. And at the end, I found that the area I just cut, the surface is very clean and parallel flushing with the surrounding endometrium. The one that you excised, there is like a bumping or gap. So you mean you removed part of the myometrium. And before I start, I tell you a new concept about the embryology of the septum. It's my theory. And the proof is very easy when you see my videos. Classically, we used to say that, to teach that the uterus develops by 2 Mullerian ducts. They travel and come close to each other and fuse. Failure of absorption of the midline septum and stay, this results in septum. This is the classic teaching. My theory, nothing come from nothing and nothing go from nothing. There's nothing called resorption. Embryologically, tissues migrate, does not disappear. You remember the undescended testis? It's here and migrate. So in my opinion, what you call it septum, anterior wall, posterior wall, the midline structure are muscle fibers between anterior and posterior wall joined together, and embryologically it should detach, migrate, some fibers goes anterior, some fibers goes posterior, and incorporate information of the wall of the uterus. So in my theory, the septum does not disappear embryologically. These fibers belong to anterior and posterior, and septal surgery, when you cut, you complete the unfinished job of the embryology, right? You complete, you just give it a chance to release the fibers. So what is my proof? Look at my videos. Look at it. See, when I just touch the septum, the fibers retract and jump and disappear. Because so the concept of excision and removal, I think it's not correct. And I have an inside feeling that those who published this paper was deliberately just want to say opposite what I say, okay? When you want to say right, no, it is left. And the proof is visual. You see it very easy. So up till now, there is no evidence that excision is better than just cut and leave it. And the tissues will heal and you will have a nice cavity. If the patient is eligible for IVF, she can go after 2 to 3 cycles. It's better to do office hysteroscopy before that to confirm complete healing of the endometrium and to check sometime there is a fundus refusion. So you pack by pressure of water or one cut by the scissor, you can remove this fundal notch and the patient can go for IVF after that. No indication for cesarean section. She can have easy normal delivery. There is also in the literature that cases with septum, they have an associated 30%, they have an associated cervical incompetence. That's true. Okay, should we do cerclage? No, I will tell you why. Okay, wish me luck.
So we are ready with the septum. As you can see, you will see both the pictures, external and internal cameras. What right now you're seeing is the patient is getting ready, and the picture on your screen which is coming is the camera which is hanging on the endoscopy camera. So that's why it's just moving, and that's what's hanging there. Yes. उसका light नहीं on. Light on.
And to see.
So both pictures to go out.
So this is the basic set of office. This is the basic set of office hysteroscopy. We have the camera, and this is called Hager. This model is called Shawki Eagle Eye. It's a CMOS technology. CMOS is a new technology in camera called complementary metal oxide semiconductors. And then we have a 2.9 length mounted on a sheath, inner sheath. And always remember that the rain comes from above, water from above, and the light of the sun rises from below. So you'll never forget it. I'm a good teacher, and I want you to be good students. Sunlight from below and water tubing from above. And then we put the camera, and you hold the camera like this. It is not like laparoscopy, you hold the camera like that. You have to see the camera control, because if the camera rotated during work, the left becomes right and the right becomes left. This is the 30-degree lens, okay? So white balance done or not? Done, okay. 250, please. Yes. You stand in front of the patient with the direction of the telescope facing down, because the vagina is not a straight canal, it is downward slope. And then the patient, where is the water? Okay, wait. Just I'm rinsing the vagina from the mucus and do like this. This is cleaning the vagina. And then I will ask my assistant, Mr. Vishnu, okay, to close the vulva. And by this, we achieve ballooning of the vagina. You have a beautiful view. Look, Mr. Malhotra. That's a fantastic vaginoscopy. This is the lateral vaginal wall. And here, look at my hand. It is all, Naharika, it's all rotatory movement. It is not side to side. Okay, it is rotatory movement. I call this cigar. Look at the cigar. Cigar grip. All right. And this is the posterior fornix. And if I did a stab by a scalpel here, you are between the two uterosacral ligaments. So in vaginal hysterectomy, you see this white line? Beautiful. And then those who are fans of colposcopy, are you tired? No. Okay. So you can examine the cervix better than colposcope. You have Angelina Jolie's lipsticks. You see that? Okay. And that's a columnar epithelium. That's a stratified squamous epithelium. And the junction between them is the transformation zone. So you can check for early detection for malignancy. Give it the time to clean the mucus like this. I'm cleaning the mucus. And then I say, open your mouth. Close your mouth. Open your mouth. Naharika, what is this? Nabothian cyst. So you see the value of diagnosis, that's the Nabothian cyst. And then we drive slowly. Relax your hand. Relax your slowly. And give it time. I want a kursi. Okay. And Naharika, look at this. A beautiful view of the endocervix. You see that? All right. And this is the internal os. Another Nabothian cyst. And this is the internal. This is the correct insertion view, Naharika. This is wrong. Look at this is wrong. This is you are hitting posterior. You have to see only anterior. And let me demonstrate the camera well. And then push slowly. Now I will sit in the kursi. Okay. And I push down slowly. Look at the insertion. And we have a beautiful double septum. Okay. It's not exactly this. I was just saying this now. When they get pregnant, they had adhesions. All right. Give me the scissors, please. Scissors. Come from here. Bindalji. Be ready to raise to 300 if I tell you. Okay. All right. Put goes. So it will be a double procedure, an adhesolysis, as well as you have one cornea here. That's the best proof, Dr. Jadip, that we should treat the septum as soon as diagnosed, because otherwise we will have an adhesions, all right? So the other cornea is not very well visualized. So I go like this. And you see this, Naharika? Gentle, and then cut. I will cut the adhesions first. Cut this part. You see the other cavity now? This is adhesion, not the septum. And cut. Gentle and cut. Now you see the other corner. You see that? You are the beautiful one, Mr. Malhotra. Exactly in the middle. Why I'm working quickly? Just to impress you. Just to impress you, and maybe I get a kiss from Naharika at the end. Naharika, I finish the septum here. You see that? And then I go here. You see the
have to
retraction?
work fast in the cavity.
Dr. Jaydeep, please look. Do you see any residual tissues? It retracts, okay? And then I could do it with the resectoscope, but it is more fun with the scissor. More fun, more fun. And your landmark is this tubal ostium. So your eyes should be on the tubal ostium all the time. And now I can see the fundal myometrium. I go like this, like this. Mr. Malhotra, are you happy?
Very happy. So why someone asked you're doing fast? Because all hysteroscopic surgery should finish fast.
Yes, and
Otherwise
also
the water will go in and
I am cutting into blood vessels. Actually, why there is no bleeding, Mr. Arvind Bindal? Because of the pressure. So this is one tubal
He will
ostium.
just show you bleeding also occurs.
I will show you bleeding at the end, okay? These are blood vessels here. I'm cutting. Cutting more than this, you will see now. If I cut more, you will see something yellow. All right? And I don't want to see something yellow or smell something bad. I finished the septum. Everybody's happy?
Yeah, tell us how do you think it is complete? Because there was a recent study which says that there is a residual septum always after a few weeks, which you will see on ultrasound.
No. It is sometimes refusion at the funnel. Look at this, Mr. Malhotra. Okay. This transparency means I have to stop. If I cut more, I'm into the steroid. And you should know, Naharika, you know the football player who plays with his foot. This is my game, okay? I go like this, I cut, and just to show off, all right? And this is gentle cut. You see, this is gentle cut. Hysteroscopist should be very gentle and handle the tissues as you are touching the hand of a beautiful lady, okay? Like this. And then everybody's happy?
Yeah, you can see the
Everybody's
pink,
happy?
area there.
Thank you very much. Thank you. So actually, it is a 3-minute job if you know the way and you have good distension.
No, Osama, you have to. Osama, you have to tell them why we have to do a complete job, because whenever residual septum is there, your myometrial contractility definitely is going to be disturbed.
Yeah. I hear this comment from patient. They said, my doctor said we will do it in 2 sessions. There is nothing called this. You don't know how to do it, all right? It should be one. As you have seen, it's so easy if you see well. If you see well and you put your landmark, both tubal ostia, then you can position a straight line. Definitely, I took the risk. In this case, I don't have a 3D ultrasound, because if there is a fundal notch, the perforation will happen. But because of my experience, I can feel if this is still, there is muscular zone or I'm on the serosum.
And that's another important aspect where pressure comes into play.
Yeah.
In such a cases, because if the pressure is good, then you can see everything very
Exactly,
nicely.
exactly.
If the uterus is not expanded well, then you're going to do an undercorrection.
Exactly. And as Dr. Jaydeep said, hysteroscopy, it's all about manipulating intrauterine fluid pressure. There is nothing called high and low. It is always the proper and the adjusted level. So I asked him to increase or decrease to keep the cavity stretched, and the little bit high pressure helps in aqua dissection. If you focus well during my cutting, some of the fiber retract by itself. Okay. Well. Why you're so calm? No, in my workshops, this is not the usual. No, when I come, they jump and they hug and they kiss and you should express why I'm working fast and dancing with the scissor just to trigger your enthusiasm and to catch your love and no. You are very sleepy. No, I'm sorry.
She's from Bangladesh.
Bangladesh.
From Nepal.
Oh, Nepal,
And
my
they're
love.
all from Nepal.
I was in Bukhara and I operated in Kathmandu. They are so nice people.
We have attended the conference
In-
before also in Nepal.
So why you don't jump and hug? Okay, actually, I learned this mission from Malhotra to travel wherever in the world to help people who cannot come to you. So let's take a promise now from the big boss. She's the big boss, okay? To arrange 3 days program for uterus in focus, ultrasound, IVF, hysteroscopy, day for each in Nepal. You are the organizing person and she is chief in command, okay? No, but give me time. I want to come with you. I want to come with you. So I was just telling you in the start that it's better to treat the septum before getting pregnancy. Otherwise, adhesions will happen. And you have seen the live example. Because when pregnancy happens in one horn, it's difficult to evacuate the uterus. And misoprostol doesn't work well. And curettage, whatever you are a good surgeon, you miss where to go. Actually, going into the uterus blindly by a curette is like going to catch a chicken while you are blinded, okay? He's running and you don't see well. Apply this for a polyp, for biopsy. The hysteroscope is your third eye. And my ambitious that one day we can train all gynecologists. I'll be honest. I'm not aiming that to train you to do difficult septum or difficult myoma. I'll be a liar. It will take a long time. But I want everybody to be able to enter, look, and to identify what is this endometrium. The same like dermatologists look at the skin and say, this is normal skin, dermatitis, psoriasis, eczema. Proliferative, secretory, luteal phase defect, hyperplasia, carcinoma. Imagine the value of diagnosis in the office. And then you take a small strip of biopsy, you put it in a bottle, ma'am, go to the pathology. You can do this in the office and charge a little bit more. If you take like $5 in your consultation, if you make it $12 and you do the procedure this way, it's a great chance. So every gynecologist should have an ultrasound machine and an office hysteroscopy set. And same like cardiologists have the stethoscope. There is no cardiologist working without a stethoscope. So you should have your hysteroscope. I tell you also one social advice. Who are successful person? The one who can see one step ahead of others. Like for example, my professor, Dr. Abulghar, when there was something called IVF, nobody knows IVF. And you know, it's a loser, success rate was 8%, and it's a fake, they are quack. He decided to go through that. And he suffered a lot of resistance. Now he's on top of the world. If Narendra Malhotra know that, they will make an airport in the land behind here. So we go and buy a little bit of land for a small price, all right? After 5 years, the price varies. So when I started my career, I was purely laparoscopic surgeon. At that time was the late Rakesh Sina, Hafiz Rahman, Prashant Mangi, we're all in the same group, younger and ambitious, after laparoscopy. Even my inventions in the catalog of color stores was laparoscopy. There's some Shawki forces. And then by time I realized I could read the future, okay? Laparoscopic surgery provided great advancement in general surgery, like cholecystectomy. Cholecystectomy in the past was terrible cochlear incision to remove little gallbladder. So now laparoscopic cholecystectomy definitely deleted. But when you look at gynecology applications, laparoscopy TLH, okay, nice. The uterus is already hanging outside. You say, hello, pull me from below. All right. And even if you are not a good laparoscopic surgeon, mini phanestoel, pull the uterus out, 2 clamps, cut, suture, go home next day. Same like laparoscopy. Okay. And even phanestoel incision is more cosmetic than 1, 2, 3, 4 puncture in the belly. If she's wearing bikini, oh, you did TLH. You can know that. You did TLH. But if she has a phanestoel, nobody will know that she did. So actually, I had a patient. She's Egyptian, but married to a prince, Saudi prince. And her husband, Saudi Arabia. So she came, she had multiple fibroids. I told her she had to do hysterectomy. She said, oh, but if my husband know that I removed the uterus, he is idiot. He will think that I'm not a good woman anymore. I said, okay, it's the problem with your husband. It's not my problem. You have a pathology. He said, please, I don't do anything, but don't do hysterectomy. I promise something. I will do hysterectomy, and your husband will not know. Okay. And this was 8 years ago. And up till now, her husband doesn't know that she removed the uterus. So I didn't think the TLH added more than just glamour to the surgeon and name and fame, big monitor. laparoscopic myomectomy. Okay. So you puncture the belly and harmonic and DDD, expensive products and V-lock and to remove a myoma. I do mini Phanestoid, get the uterus out and do perfect reconstruction, put it back and close. There is no study proved that the scar after laparoscopic myomectomy is same or better than abdominal myomectomy. The few studies showed that the adhesions after laparoscopic is less because the publisher was one of the top competent laparoscopic surgeons. Okay, so even the FDA now abandoned morcellation, and this will kill laparoscopic myomectomy. But those stubborn people who had some values, some benefits, okay, we will do morcellation in a bag. Imagine the amount of complication they added, a bag, although the alternative is much more simple. So I could see that laparoscopic surgery will not live long. In my honest opinion, laparoscopy in gynecology only ectopic pregnancy, tubal disconnection, finished. Some ovarian cysts. Endometriosis is turned to be a medical disease now, all right? And those terrible endometriosis, deep infiltrating, it's not for gynecology. It's not your job. You will never be like Sanjay Patel. His name is Sanjay Patel. You know Sanjay Patel? He's one of the top surgeons here. You'll never be like him, okay? He cut the bowel, he cut the bladder, and okay, this is his job, all right? So I want you to read the future. And actually, I do thank very much the IVF people because more development IVF highlighted very much, you need me, I am the boss, okay? And then I give them better results and then they send more patients to me and that's it, okay? Definitely, I'm trying to push the concept now, routine hysteroscopy for IVF. I make a lot of money, okay, with that because every IVF, they said, no, it's not ethical. We will send you only the failed trials. Okay, they have 60% failure. Let them send it, all right? The failed trial is enough to buy a Ferrari, okay, in 1 year, all right? So, and by the way, we make profit much more than them. She spent 1 month with the patient, induction, ovarian hyperstimulation, and then she takes these rubies, okay? I spend 5 minutes, okay? And 2-3 cases like this, I take money more than her, all right? So hysteroscopy is a beauty. Yeah. I swear to God, I visit many infertility centers in India and all over the world. In one of the centers in Kurdistan, the director is very nice, beautiful lady, same like GD. She had a very humble center. After 3 years, she said, Osama, I'm going to build a new hospital. She called it Royal. It's fantastic hospital. 9 operating rooms, glass windows. So I told her, from where IVF is making good money? She said, no, it's your hysteroscopy make us this money so we could make the new hospital. So hysteroscopy is the backbone for gynecologists, right? 80%, after some training, 80% of the procedure, me and you will be the same. But 20% of procedures, nobody will be like me. Okay, still, you know, it will take. So I will go for the next case and come in.
He's saying 2-3 people are there to.
Okay, put them. When legs up, call me. And put
that case, that one.
here.
It's ready. We have some hands-on.
I will let them go. Yes, I will. Okay. Vishnu, Mr. Bindal, can I ask of a $100 bonus for Vishnu, please? Sure. And by the end of the day, it will be more, or we will let him pay penalty. It depends on. Shallow. So your name is?
Samruddhi.
San. Okay.
Samruddhi.
I will call you Sam. Okay. Sam. Okay. So you have seen the movement of hysteroscopy with rotating and up and down. Inside the trunk cavity, because it's small, it is more difficult. But I will let you do the same movement inside the bigger cavity, the vagina. So the training inside the vagina is a copy or mini image of training inside the uterus. 7. Bindle. So my dear friends, now you have an opportunity to compare between different products. This is a Striker camera, and yes, Striker is a good brand, but maybe 3 to 4 times the price of the Shawki Eagle Eye. So Mr. Bindel will be very pleased and happy to prove to you that quality is the same. Even I find mine has some advantages. Okay, stand in front of the patient, hold the telescope like this. Your name is?
Dr. Ila.
Ila.
Yes.
No, you are very tense. No, hold my hand. No, you're very tense. You see how I do my training?
Yes, sir.
Okay, no, I have to feel your muscle. Okay, now you are much better. Now you are much better. Elbow up. No, slowly elbow down. Extend, flex. Yes, okay, now your muscle is more relaxed. You hold the camera as if you are holding your baby or the hand of your husband, okay? You hold it very gently and your finger like this. And this button should be viewed, right? Stand exactly in front and don't look at this is wrong angle. Binderji, this is new teaching. You didn't hear this. It should not be like, it should be like that. It should not be like, it should be like that, okay? Hands down, open the water.
Open the water.
He's open, he should open it, yes. Okay, make sure there are no bubbles. You see these bubbles? No, forget this, forget this. The other hand should be free, yes, no, free, like that. And then direction down, clean the vagina. We are cleaning the vagina now, yes, to remove the betadine. And then Vishnu will close, and then hands down. Excellent. A little focus. Yes, there is no Angelina Jolie's lips here. Okay, so now we should have a nice panoramic. That's panoramic view. This is not nice. This is a nice panoramic view. Okay, this hand is steady. Other hand, so when I say steady, don't do like this. Steady. Okay. You see, rotation happened. It should be like this, not like this. Okay, steady. The other hand will hold the light cable like that. This is the light cable. Hold it from the metal. Okay, and then rotate. This is one lateral wall. Rotate more. That's the posterior wall. Rotate other side more. Okay. Yes, the other lateral wall.
Of the vagina.
Open your fingers so I can do focus. Okay, and then slowly come in to enter from external os. This is wrong view because you're going posterior. You have to look to the anterior lip. Okay, this is correct view. Okay, next doctor. Come, Sam. Your name is?
Soumya.
Soumya.
Also Sam.
Hold the camera one hand. Yes. I want you to be very gentle. Very. Okay, you see how Soumya is moving? It's not like this. Very gentle. Now we will do different technique than your friends. Instead of rotating the light cable, okay, you rotate the whole system. Look at this. One lateral wall. It's all in the wrist. Other lateral wall. Okay, then hold the light cable. And you always keep a central view. If you rotate like this, correct yourself. And that's the posterior wall. Are you happy? I can see happiness in your eyes, all right? And then come slowly in, hands down, bravo. And another Nabuthian cyst, okay? Enough. You're welcome. Next doctor? Sam, you have lovely eyeglasses. I admire it, okay? Although I am busy in teaching, but I take care of very minute details, all right? So this is a panoramic view. Sam, stand in the middle. Give me panoramic view. No, panoramic, stay, this panoramic view, okay? Stay like this, and let me hear your voice. Count loudly from 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Excellent. This is, I call stability test. If you are not stable, 1, 2, 3, 4, 5, okay? So she's very stable. And now rotate. Where is Naharika? And rotate. I want to know the indication of the case.
Yes.
Okay. And now come close, hands down. Hands down. And go slowly. Slowly. This is the columnar epithelium. And another Nabatean cyst. Same. Complete septum. Okay, leave it to me. Stool. The septum is reaching the level of internal os. You see that?
Yeah.
Okay. All right. So give me the scissor. This is more difficult than the previous case. Can we have all table up, please?
Again, using cutting scissors.
Yes, faster. Binderji, what is the pressure? 250, okay. Okay, so we start. No need. Okay, and I go in, slowly in, and see the scissor, see the septum, but it's actually narrow. Look at this movement, huh? And the same here. And then we go like this and cut. And we glide in and endometrium is a little bit thick. I want to cut the endometrium, see the, okay, this is one direction. Actually, we should operate in the proliferative phase. So this is the other direction. Endometrium is very thick, Dr. Malhotra. Huh? You make life difficult for me. You see, when the endometrium is thick, you don't see well, but I'm trying to remove it so you can see better. I enjoy this more. I find there is more art in that. But if you want the resectoscope, I will put it. Okay, the tubal ostium is here. There is some bleeding here. So we will cut it, and don't be afraid. Tubal ostia here. You see, it's 1 minute work, okay? This is one ostia, all right? And the other ostia, the thick endometrium makes it a little bit not comfortable, but I'm trying to finish quickly. And you have to stay in the same line. When you see the ostia, you tell me, otherwise I will see the bowels, okay? Okay, this is the ostia. Vishnu, all the time you adjust this, okay? According the width, all right? Some little bleeding because the pressure is not enough. But there's no how much, it depends on the, you see, this is not comfort to have this wind endometrial. So here is completed. Then I go to this part, I keep it till the end. You see the retraction? resectoscope can do the job, but this is more art. You see, here is perfect, and here is perfect. I have to remove here a little bit. Exactly in the middle. Cut and escape. I will show you some bleeding to frighten you. Okay, so this is the level of the ostium, and this is the level of the, you see the pulsating vessels? I think that's enough. Septum is muscles, is not fibrous tissue like people used to think. Don't afraid about this bleeder, okay? You see that? I can make like this and cut only the fibers. The vessel is free. Okay, are you afraid? Leave this, leave this. No, I will show that it will stop. Okay, so now there is no bleeding. There is one tubal ostia here, and that the septum all the way. Okay, again, that's the tubal ostium, that's the septum all the way, all the way. You see the fibers retracted between anterior and posterior wall. Okay, everybody's happy? You see, we started from here. That's the cervical part, okay? Everybody's happy? Thank you, thank you.
Someone is asking on the online, what do you do with the hanging flaps which you see sometimes? I think those are.
Okay, there is never hanging flaps. There is never hanging flap, no. One more thing.
Whoever's asking hanging flap, I don't know what you mean about hanging flap.
Very minimal bleeding. And I want to comment about the bleeding.
So sometimes in the endometrium, when you are pushing the hysteroscope violently, the endometrium may shred off, and that may look like a hanging flap inside.
Again,
So nothing to do about
some
that.
colleagues is asking, thank you, thank you. One colleague is asking, what do you do about hanging flaps? There is no, Dr. Tandon. Oh my God, that's the Maharaja of laparoscopy. No, give me a hug. The Maharaja Tandon is a very competent laparoscopic surgeon. And he comes from a very big family. His father is a great doctor. And he is married to the Miss Universe. But tell me the secret, are you taking stem cell or PRP? Because you look younger than last time. I think, no. I do gym, but I think your sister did some job for him. Okay. Okay, I'm just doing promotion for his sister because she's a plastic. Well, so there is no hanging tissues at all. But the challenge in this case, two challenges. The septum was very long till the internal os. Okay. So if you go quickly by the hysteroscope, you might bypass the septum, go into one cavity, or you hit the septum and you make shreds. This one. The other challenge, because usually hysteroscopic surgery should be scheduled post-menstrual.
So one more question here. Diadelphus uterus, hysteroscopic, next case is diadelphus. So what we can answer.
Through diadelphus?
Double uterus.
I mean, separate corners?
Yes.
Okay.
We'll put the laparoscope and see. I think we're suspecting that.
All right.
The next one.
But
she's asking you the question how to separate.
Okay. I will do a comment also about do we need laparoscopy or not. So the other challenge that this was nearly premenstrual, endometrium was very thick. So when you cut the endometrial flaps, make shreds, and the telescope lens is 2.9. His telescope is 10 millimeter. So 2.9 is very small. If this shreds is 2 millimeter, it hides the whole view. So I have to manipulate to go away from it, but it doesn't let you feel comfort. It's very difficult for a beginner to do a case like that. So the final judgment at the end, the beautiful view, 2 corneas and wide triangular area till the cervix. I didn't do the step to frighten you. If I shut off the inflow, you will see a pumping fountains of bleeders. Fountains. It's not like that. Okay, it is scary. Okay, maybe I show it in the next case. Should we do cauterization or put a balloon? Absolutely not. Absolutely not. I remind you that after delivery of the placenta, the placental sinuses is like this size, and it is this is the gush of blood after placental delivery. Does it stay for long? No. So as you have seen, contraction of the uterus will happen and definitely will stop there. I always teach there is nothing called bleeding in the complications of hysteroscopy. And if I see any speakers giving a lecture about hysteroscopy and says bleeding, I understand that he didn't do hysteroscopy. He just speaks, but doesn't know, okay? I use always to say this until one time happened with me, complication, okay, in Jaipur. Dr. Sushila said. She brought for me a huge submucous fibroid with a big broad area. And I went tuck, 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 finished. A lot of beautiful girls watching. After I finished, I decreased the pressure, fountain blood. Sir, what do we do? I said, oh, come on, don't worry. I'm a big man. Trust me, it will stop. And I left the room to get some coffee. Then a little doctor, young, sir, please come back. There is some bleeding. Oh, no, you are a little child. And then the anesthetist came. If the anesthetist is coming, you know something wrong. Sir, you better come back. We have a problem. I moved to the OT. I found a flood of blood. You know the postpartum hemorrhage? A flood of blood. And I was trembling, lost my confidence. What happened? So I told him, okay, bring me back again the resectoscope. I'll go to cauterize. Oh, sorry, the resectoscope is in the sterilization. We still need 10 minutes. What to do? So I behaved the same like atonic postpartum hemorrhage, bimanual compression until we bring the resectoscope. So while doing this, I moved my eye to see the vital signs. And then I found the surprise. The blood pressure was 180 over 120. So I told the anesthetist, why you didn't tell me this? Because the mechanism of hemostasis depends on muscle contraction and blood clot will stop. But here, because of the high blood pressure, there is no chance for clotting mechanism. He said, no, but I thought it's none of your business. I said, no, it is my business. You have to tell me she had such severe blood pressure. I kept like this, then they said, okay, the resectoscope is ready. I removed my hand. He lowered the blood pressure. I removed my hand. There is no single drop of blood. The question now, should I go by the resectoscope and check and cauterize? Never, never. It will excite bleeding again. Because if you stretch the uterus, open the vessel, it will, no, so never do. So this as regard bleeding. There is no worry of bleeding at all in hysteroscopic surgery. Patients do not die from blood, they die from water, absorption of fluid. They asked me here, why you use the scissors and not the resectoscope, although most of my surgeries that I do in my center by the resectoscope. Number one, with the scissors, you can use saline. Resectoscope, if it is not bipolar, you're going to use glycine, which is electrolyte free, which is extremely dangerous, and please never use it. Okay, only normal saline. Forget about me, I am crazy. I use monopolar, and this is not correct, right? But I finish in 10 minutes or 5 minutes. But if you spend more time, the patient will suffer electrolyte imbalance. Second thing, which is more fast? Definitely the resectoscope cuts faster, all right? But in my center, I have the larger resectoscope. I don't have the small one. So still I have to dilate the cervix. So this takes time. So I find when I'm with the office scope without dilatation, bring the scissor, and you have seen the time, it's hardly 4 minutes, okay? Both can work well, and there are many studies done comparatively between scissor and resectoscope. The healing is the same, the outcome is the same. But for the beginners, scissors is much safer. If you perforate with the scissor, no worry at all. In my center, not here, I deliberately, okay, perforate by the scissors, show them, don't worry. I cannot do here. Narendra will be panicked, okay? Scissor is like an intramuscular injection, okay? The muscles will heal. But with the resectoscope, the perforation is a burn. So the healing will be by fibrous tissue. And if the resectoscope pass beyond the serosa, you can touch the bowels. So if you want to do septum surgery, start by very mild arcuate uterus, short septum, and by time you can do the complete. Uterus didelphus is another category. The two Mullerian ducts have never come near each other. They stayed like this, and you have two uteri, each one with its fallopian tube and with the round ligament and ovary, okay? So Narendra said, we will invite Dr. Tandon to do laparoscopy. I think it's just a compliment for Dr. Tandon. We don't need laparoscopy, Tandon. Sorry. It's a shame to do laparoscopy to diagnose congenital electron anomaly. Now 3D ultrasound or in conventional ultrasound, even much more accurate, because laparoscopy sees only the outer contour, but 3D he can see the endometrial cavity, the triple line, and the myometer.
So in this case, there is a fibroid also.
Okay, it's his
So
game.
that is why we are doing the laparoscopy. Otherwise, 3D.
Truly a fibroid, or you invented the fibroid for him?
No. Let's see what the 3D is shown. It
Okay.
looks like but first we'll do hysteroscopy and then check
Okay.
if it is septum, then you'll cut the septum, then myomectomy.
You did ultrasound for her?
Yes.
You are better than me and him
So
to tell.
I didn't do the ultrasound myself because these people did it. So the 3D picture is there. So it could be, I think this could be
She has
septum only.
undergone one diagnostic lab somewhere else, which was failed.
To me,
It won't do
it looks like either a bicornuate or bicornuate septum with bicornuate notch. This is if it is a bicornuate with septum notch.
7 abortions.
Okay, it's the most dangerous one because you have a very short septum and then there is a bicornuate. So if you cut more, you perforate. You cannot have now the tubal ostium as a guide for you. But I think, yes, we need Dr. Tandon to do, because the 3D is not very accurate. By the way, people think that ultrasound is easy job. Let me tell you, and Dr. Narendra will agree with me, the study called CUMI study. CUMI study is congenital uterine malformation by expert. You heard about this study. It's a very funny study, very funny. They recruited top 15 sonographer and gynecologist, top. And they distributed images of ultrasound congenital uterine anomaly and asked them to write his comment. So these are the top. Can you imagine? They didn't agree. One person said septum, no, it's bicornuate. So actually it needs the eye of an expert. And I believe definitely Narendra is the best. I used to refer my cases to sonographer, but not anymore. My son Yahya now, he is, I will not say he's expert sonographer, but he's expert in congenital anomaly. He can tell me, Dad, this is a septum, bicornuate, or with a notch.
This one is a septum for sure.
Yes, it looks.
The fibroid is very small. So
Okay.
I'm just looking at.
So you are lucky today. You have a party of septums, okay? Festival of septums. And now you can appreciate how prevalent this congenital anomaly. Even
That might be endometrial. Let's see, we put the scope in and see whatever it is.
okay.
It will take 10 minutes.
Okay. If we schedule a case for a combined hysterolaparo, me and Tandon gonna play, who should be the first player? Some people say hysteroscopy starts first. In case he perforated, he can tell, right? But also, if the laparoscopic surgeon needs to put a cannula to move the uterus, this will destroy the view for me. So I have to start first. I think we'll start together, me from below and you're from above. So I can move the uterus to you by the hysteroscope. One of the good examples of collaboration between laparoscopist and myself, I did with Nikita, a case of ismocele, cesarean scar defect. There is a debate about the correction. We like to do it from below by hysteroscopy with a simple technique because ismocele is like a pouch, collect the blood and mucus. So I converted from a soup plate into a flat plate. So there is no correction. But still, the thinniness is still there. Laparoscopic surgeons say that we are idiot because we don't reconstruct. So they go by laparoscopy and they excise this part and they do suturing. But I have seen so many cases, they did laparoscopic correction, and by hysteroscope, it is still the same. Because sometimes he cut a little bit higher or lower, and he missed the defect. So we find a nice collaboration, me and Nikita. I went by the hysteroscope, and I put the telescope into the defect, and she could see the transillumination, and she did the cutting from above. So by this, we are sure that the excision done on the defect itself. Ismocele became very commonly seen now. and with many complaints. Basically, they have intermittent spotting because during period, the blood flows down, come in this pouch and collect. Same like cystocele, double micturition. So this is double menstruation. You got the point? And also for IVF people, it's a big problem because transfer of the embryo transfer go through this lake of mucus and blood. And same like hydrosalpinx, spores, fluid, is also the ismocele retrograde blood. So the cavity is not clean. So they ask us to remove this defect or to make it flat and no collection of blood. Why it happened so frequent? Why we didn't hear about this ismocele in the past? So many explanations. People said because of the technique of closure of cesarean section, that one layer closure, two layer closure. Some people said because of the suture material. I have also another theory, which I proved by my videos. If you look, go to YouTube, say Osama Shawki, ismocele pathology proof. I found that most of cesarean section scars I see nowadays is very low, almost in the cervix. And the cervix doesn't have a muscle wall. And I could prove it. I can show you Nabuthean cysts and endocervical mucosa in the ismocele, which means that the surgeon did it. Okay. So because if it's very low, the cervix doesn't have a muscle layer and it has a mucus secreting glands, so there is the collection. So why now cesarean sections are very low than before? I tell you also my explanation.
We have some questions from our online trainees also. So they wanted to ask, what is the maximum pressure which you use, and do you give prior misoprostol before doing the procedure?
Misoprostol is fake, is a myth. Does it make the cervix softer? Yes. And this makes insertion more difficult, okay? I prefer to go through rigid cervix and I compensate by high pressure of fluid. High pressure of fluid will expand the cervical canal and you go easy. Misoprostol makes the cervix gelatinous, soft, so you easily make a soft track, scratches, bleeding, so it is not nice. This is about misoprostol. About the pressure, there is no number to tell. It is not like laparoscopy. Laparoscopy tendon, say to them, put it 15. And then he doesn't think about it and keep operating for 4 or 5 hours. Okay, and when he wants to clean or to remove the smoke, he opened the outflow. In hysteroscopy, every minute change. You want to go high and down, it's dynamic. It depends upon expandability of the uterus. And in laparoscopy, there is no orifices for leakage of the gas. But in hysteroscopy, you have the open cervix leakage and you have the fallopian tube. And it differs from one patient to another. So what could be suitable 150 pressure, it cannot be suitable in the other case. It's not like laparoscopy. So the pressure is simply whatever number enough to separate uterine walls. This is for diagnostic and see well. For operative, whatever enough to expand the uterine walls and compress the bleeders. So in the last case, there was some bleeding because the pressure was less. Why it was less? Because the inflow channel is the same channel for the scissor. So when I put the scissor, the flow is less. When I pull out the scissors, the flow is more, and then there is no bleeding. I was saying something important before I say this. Yes, well, yeah. Why cesarean section incision now very low? Why the surgeon of today different than surgeon of yesterday? I tell you the secret. Most of cesarean sections in the old days were not elective. After trial, push, oh, sorry, we go to the section. The lower segment is stretched. So the incision is really in the uterus. Most of cesarean sections now are elective. Ma'am, come fasting in the morning. And we used to teach the residents, dissect the bladder, go down, 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 and then open. Actually, you're very near to the cervix. So that explains why the rising incidence of that defect, which was not existing in the past. This is my theory. Sure.
When you were cutting that septum, which was thick, you cut in the midline. But what if there's some tissue left antero-posteriorly? And what is ideal? Incise, excise?
Okay.
What is the ideal word to use when you are cutting that septum?
Ideal.
Incise or excise?
I mentioned this to you. There is only one recent publication by Dr. Bitoki and his team in Italy, describing that the septum should be excised, removed, assuming that this septum is extra tissues, should be removed to resume normal, as if you have number 6 finger. So you remove the 6 fingers to have normal hand. That was the concept. And that was the old surgery, Jones and Thompson and Johnson and Johnson, where they cut a wedge, move the septum and suture. But this is the old concept. But if you follow back and you remember the surgery I've done, or you look at my videos on YouTube, I have a very nice video called The Evidence for Septum. Just when you touch and cut the septum, the tissues retract. The septal tissues are muscles under stretch. So if you cut exactly in the mid-plane, it retracts. There is no residual tissue. And maybe what you have seen here is what's endometrial shreds. But the white septal tissues, there is no any hanging or residual tissue to be removed. And I do believe that excision, as if you are removing part of the myometrium. And that's not good. Dr. Kumari. Kumari is the president of Foxy now?
Yes.
Really? Oh my God.
This is the Young Talent Promotion Committee of Foxy.
Yeah, and Basab
he's the
Mukherjee
vice
from
president.
Kolkata.
Yes.
Kolkata.
Yes.
And Kumari from which city?
Hyderabad.
Hyderabad, yes. And who is this beautiful Bollywood star? Am I correct? Really? Beautiful Bollywood star. So there is a lot of misunderstanding about septum and about hysteroscopy regarding the fluid pressure, regarding the techniques. And also, I have an explanation for this. Laparoscopic surgery, when started, there were so many experts doing it, all right? So you could listen to many opinions and then you reach conclusion. Hysteroscopy, there were very few. Look around you, how many good laparoscopic surgeons, how many hysteroscopic, very few. So for a long time, opinions were dominated by very few opinions. There was no chance to listen more and more. But now, after many doctors started to do hysteroscopy and they understand well and they can see well and they can build their own opinion, I think in the coming years, everything will be standardized. Like the concept of intrauterine pressure. They were very afraid that if you raise the pressure more than a certain number, the patient will die.
So very interesting case now. She is a patient of recurrent pregnancy loss. She has had almost 7 abortions before and one failed diagnostic laparoscopy. They couldn't insert the I think, which was done
Vishnu,
in Jhansi.
are you ready?
And her ultrasounds show
I'll make it
bicornate uterus
$150 bonus.
with large hemorrhagic
But at the
cysts
end of
and
the day,
small
Either
intramural
to ignore
fibroids.
or cut
So
this.
it will be a laparoscopy with
Can I have
hysteroscopy now.
sterilium on my hand?
4 people can go inside. 4 of you.
Dr. Tandon ready or not?
This picture you cannot actually, ideally with us, you're doing a good 3D ultrasound, you could have
Can we push this a
told that
little
whether
bit
it's
far away?
bicornuate or septate. But in this picture, you cannot. So once we put the port, we'll understand what exactly it is.
Thank you. What's your good name? Gudu. Gudu. Gudu is good.
This is that case which is query
Query,
bicornuate.
we will check.
Had 7 abortions.
And Dr. Tandon is ready in case?
Dr. Tandon is here, yes.
Can I have a little gauze, the small? White balance done. Can Can we bring the monitor? Usually we ask anesthetist that this hand to be flexed, and we'll bring the monitor here because it's very far from me. Yes, more close. Bindle G, water, fluid on, 200. When you swab with betadine, it's better you remove it by white gauze. Okay. And this one. Okay, close. This is another challenge here. The challenge is that the cervix is pinhole. Yeah. Okay. Bring me a white gauze to clean the vagina. Vishnu, white gauze to clean the vagina. So while I'm preparing my hysteroscope, Dr. Tandon now is pushing the varus needle. Look at his hand. He holds the needle like a pencil and gently feel the feedback tactile. You see, I like what he's doing. Wait, he doesn't elevate the abdomen very much. He just feel the resistance. Okay, and 2 clicks. Puck, puck. Now he elevate and have you felt it? I'm not saying have you seen it. It is felt, not seen. Okay. Okay. Hold the telescope like this. Yes. All right. Your hand should not be like this. It should be like that. Aim down and open water, but I don't. Water, please. Close, Vishnu. Don't put the, stretch your back, straight shoulders. Now you are in contact with tissues, pull back a little bit. Yes, stop. And that's, no. You should not see this. Hands down. No. Your movement should be like that. You see the movement? It's not like this, okay? All right. Vishnu. Are you ready, Vishnu? Okay. I think Vishnu is not able to do good. Okay, this is lateral. What is this? There is a cyst, small cyst here. No. It's the Rouget. And actually, this could be a coital injury. There is some scar here. You see that? All right, I'm waiting. Are you tired? We are waiting until Vishnu. Take your time, Vishnu. Take your time. So Vishnu is closing the vulva. You are resisting me, okay? Be flexible, okay? So this is one lateral vaginal wall, other lateral. This is a little scar here. This could be from intercourse, and the cervix is pinhole. Here is the posterior fornix. This is the lateral fornix. Get the movement from my hand, and then to enter the cervix, you have to look to the anterior lip. This is correct. This is wrong. You see, this is wrong, huh? Like in this, correct. All right. Next, doctor. Come. Hold the camera. All right. Pull back. Stay like this. Count from 1 to 5. Madam.
Yes, sir.
Count from 1 to 5 loudly.
1, 2, 3, 4, 5.
Okay. You are a little much better. Now with the other hand, hold the light cable. That's the light cable. This is steady. A little bit down. Yes. Keep rotating. Keep rotating. That's the posterior wall. And that's the other lateral. Look at her hand. And then back. Okay. This is the same movement you do inside the uterus, but inside the vagina, you have more space. Show me how to enter external os. Yes. Excellent. Look at the anterior lip. She is afraid to hit here. Actually, you're correct. This is correct. This is wrong. You see, this is wrong. Like this. Now you're no. At the last moment, you made like this. No. Keep it like that. Yes. You see this? And this is the endocervix. Next, doctor. We are using saline, huh? Okay. In laparoscopy, you don't need to change the focus every now and then, but here you have to do. This is steady. Rotate the light cable. Yes, more. Madam, more. More. Yes. Are you happy? Other side. Okay. So this is steady and this rotates. Show me to enter external os. Wrong. Very wrong. Madam, look. This is the posterior lip. This is the anterior lip. I want you to hit the anterior lip. Hit the anterior. Hit the anterior. You are correct now. Leave it to me. Corsi. Leave it to me. So the external os is very narrow, although she had multiple abortions. This is a perfect cervix. There is no erosion. I'm trying to go from the narrow external. You see, I'm in. This is the endocervix. Okay. Beautiful view of the end. Sir, your camera in front of me. Go back a little. Yes, thank you. You have to clean the mucus. So I open the outflow, clean the. If you get lost inside the cervix, Dr. Tandon, take these lines as your guide. These are the tram lines or the train lines. Okay. Follow the lines, hands down. This is the internal os. Can I have all table up? This view is wrong because I hit in the posterior wall. More hands down and glide without friction and rotate like the pilot landing. Okay. And that's a septum definitely. Okay. That's a septum. I'm going to one cornea. This is a septum, and again, very thick endometrium. Okay. So for change, would you like me to use the resectoscope or scissors? It's up to you. Okay. Bring the resectoscope. You want to have a look from above? Okay. So Dr. Tandon will confirm now by a look by laparoscope. Some more important tips. Before laparoscopic surgery, Dr. Tandon asked the assistant to evacuate the bladder. But in hysteroscopic surgery, don't evacuate the bladder. Don't evacuate the bladder because we need a full bladder to correct the anteverted uterus. You like this?
That is important.
I'm giving all my secrets today, just for your eyes only. Resectoscope. Can somebody remove the water under me? So now you will see some water inside. This water is because of the full bladder is obvious. And he cannot see the uterus. No, he can see the fundus of the uterus. You can see it. Unfortunately, I will not be able to put a uterine manipulator for him. There is an ovarian cyst. It looks like a hemorrhagic cyst here. Ready?
Ready.
Can somebody remove the water? White balance, yes.
Very important to see the pictures yourself and read the reports.
Colors are very strong. It needs some focus. Let me try to push the uterus with my hand. Oh, that's the uterus, okay.
Yeah, so you can see the dimpling on the front.
Okay, make focus, please. Focus. Focus. You see there is a fundal notch. So Dr. Jadip, I will not do complete excision of the septum. There is a fundal notch. You see that? And there is a hemorrhagic cyst. Be careful. Don't ever, never operate in hemorrhagic cyst, all right? It will end in oophorectomy, yes. Okay. I will go now.
So we'll correct this. We can
Yes.
see that the bulge of the uterus comes back.
A little bit, yes. Yes. Can I have a resector?
very clear on the 3D picture. I mean,
Can I have a retractor and grab the cervix?
the dip on the fundus is very clear. So you can't miss
Uh,
it. If you see the.
Naharika, can somebody wipe this and put the foot switch for me? Do you have single tooth? Tenaculum? So can I deflate the carbon dioxide? Yes. Yes, better, yeah. Deflate. Keep your trocar, but deflate. Can I have OT light, please? Vishnu. Yes, sir. Hold this down. Steady, no, like this. Yes, thank you very much. Actually, this is not a single tooth, but okay. Wait. Okay, enough. Leave this, stand here. Leave this, okay. Foot switch on my right side, please, and all table up. And fluid 250. Thank you. Yes, I want you to be comfortable here. No, leave this, leave this. Just this is steady, and hold this. No, from that side in hysteroscopy, all assistant on the other side because they look okay. Leave this, leave this, okay. Water on. Cervix is very narrow. Yes. Okay. So we go slowly. Give it time for irrigation. This is the internal os. 250? Okay. And then we should see the septum as soon as we glide in. That's the septum in front of me. But, okay. So this is one tubal ostium. You see it? This is one tubal ostium. And here is the septum and other tubal ostium. Pressure more, please. Exactly in the middle and cut. You move from side to side like this. You see, again, the endometrium is bothering me, huh? This endometrium, tubal ostium, you see it? More pressure, please. When I see the cavity is not distended well, I ask for more pressure. From side to side and push. Then I rotate like this and follow on the other side. It's a very long septum. I want to finish one side and then go to the middle. It's a combination of push and side to side. People do pushing very well, but they cannot do side to side. So you have to train yourself like this. When you see tubal ostium, you tell me to stop, my friends. I don't want tendon to make scandal for me. Gently. People ask me to change, okay? It's a very long septum, so I take it in two parts. One half, this is the tubal ostium. Look at this, Dr. Jaydeep. I touch the septum and I see how much left, all right? Like the blind man with the stick, huh? You see, I glide, and Touch the septum and see how much. Still, it's a big septum, my friend. Thick and big, yes. That's enough here. And then I go to the other side and can you decrease the light a little bit? The light is very strong. Light. Very gently from side to side, very gently from side to side. Light is less, please. Light is less. This is the largest septum we did today. Today, but I did larger some. It doesn't want to finish. The laparoscopy of tendon make me more comfortable to know when to stop. So thank you, tendon. No need, no. Look, my friends, here is the dangerous part or the important part to calibrate with the tubal ostium. So to know less, still more. This case in particular needs a second look because sometimes the fundus makes some adhesion. No, still more. Still, you see how you can. This is not a perforation, don't worry, huh? This is intramuscular space. Okay, I will stop in this place and then do something in the middle, huh? Okay, look how much we have done. Oh my God, okay. Okay, this is enough. You see, this is Jadip. This is enough. In the middle, I'll be very careful because there is some notch. Everybody is happy. Here we can take some more. Still more here. You see the fibers retracts, huh? There is no remaining fibers. Here I'll be very careful and gentle touch. Very touchy, very touchy. You see that? Millimeter by millimeter. And that's beautiful. Everybody see that? I will show you now the fantastic final view. Okay. Are you happy, girls? So this is one tubal ostium. This is the septum all the way. And the other tubal ostium, I calibrate by pushing here and pushing there. There is a little shoulder. I can take this for perfection. I wish tendon will not correct any problem for me. It's a plastic surgery, my friend. Plastic means that you have to calibrate and fine. Everybody's happy? Everybody's happy? Let me show you some bleeding, huh? Let me show you some bleeding. Let me show you some bleeding. And bleeding time. There is no bleeding. Okay. Here. You see that? And by the way, you see, Dr. Jadip, when I decrease the pressure, there is no hanging tissue. This is answer about you. I'm decreasing. There is no hanging tissue. You see that? right? And the bleeder is very minimal. No need to cauterize this, all right? Thank you very much. Thank you.
How much is the diathermy setting? Diathermy setting.
The what?
Diathermy.
The diathermy. I start by 50-50, and according to the septal tissue, sometimes it has more fibrous tissue, you increase the cutting. 50-50. Yes. This is the largest septum of today. Yes, yes. Very broad. Wait. Thank you. Yes, please. Did you like that septum? Okay, so we have seen different kinds, short, long. You have seen scissors, resecto, right? But I think you put sugar in it. No. No sugar. No sugar at all. And if black would be fine, black, okay. Why I don't put sugar in the coffee? Because you're here. People say that I say compliment. I don't think it comes instantaneous, instantaneous. So, and don't misunderstand me. I don't mean anything or else.
I want to ask a question.
Sure.
We've done such a big septum, and you don't believe in putting Foley's or
No.
any progesterone.
Okay.
And this patient will bleed for a few days. No,
You are talking about bleeding or healing?
bleeding mostly because then
Yes.
patients get
Yes. But even if you give estrogen or you put a balloon, the bleeding will be more. Bleeding will stay. You have to tell the patient you have intermittent bleeding during the healing phase. Okay. You can give her only, you have here Daflon, Capron, Epsilon, tranexamic acid. It's very good. It's very good. Actually, the bleeding here is very minimal. Sometimes you see more pumping bloods. But I'm very happy in this case to prove my theory. When I decrease the pressure, the walls collapse. There is no hanging tissues.
And why do you think she
Are we
had
recording?
a failed surgery before? Yeah, because they did a surgery and
Sorry, lead my lips. Read my lips. Because I cannot say this in the really, okay. The Europeans are very good, but they are stupid.
7 abortions. I just
7.
documented abortions.
The cervix looks as nulliparous.
That's what, yeah.
I don't know. But this is not only the longest septum, this is the widest, very broad. Actually, if you look at my videos in septum, I start from one side till the end. But here I can't, it's very broad. So I finish one half, other half, and in the middle. And 99% of my work, I use monopolar. It's more enjoyable. You have to see the monopolar more enjoyable. It's like a hot knife in the butter. Okay, but the bipolar a little bit like a bold knife in the cheese, not in the butter. You like that, Rakesh? But the best bipolar is the Boers-Hager, definitely.
As I told you in the morning, the basic problem is there are two things. One is the cautery, second is the receptor spool. The basic cautery you will find in every hospital. So monopolar and basic cautery very good. Like that. But the cautery should be good, and when we use bipolar, we should have a bipolar cut and bipolar coagulation.
And bipolar underwater.
Yes, saline dissection.
Saline, not any other. So bipolar is much safer, but it's more expensive. All right, the machine, the electrocautery. The monopolar is less expensive, but very dangerous, extremely dangerous. Even nobody is using it in Europe now. But if you see how I cut the septum by the bipolar, the monopolar, you will love it. Yeah.
But sir, what we do, like sir is said, that is cheaper. We have 4 kinds of cautery generally. One is a normal cautery, monopolar cut coagulation, bipolar, 400 watt underwater. So we have 4 kind of cautery electrosurgical unit. First is 400 watt monopolar
cut and coagulation. Bipolar coagulation starts from 40,000 up to 4 lakh rupees. Second is this basic, I will say it basic model, then vessel sealer. So if we go for vessel sealer, so that is a second model, nor basic cautery and vessel sealer. Third is normal cautery, vessel sealer, and saline dissection, bipolar cut and coagulation. So generally, if hospital have a basic cautery started from 40,000 rupees to 4 lakh rupees for an example, so they don't want to buy that basic one, and most of the hospital have a vessel sealer as well. So only one model was available, in fact is available with the other companies, basic cautery, vessel sealer and saline dissection, costed 12 lakhs to 24 lakh rupees. But we are a company who have come with only bipolar cut and coagulation. You already have basic cautery, you have already have a basic cautery or vessel sealer, so you need to buy only saline dissection. So the cost is very, very less. Okay.
I was 10 years younger. Well, Arvind, no, but I'm more beautiful now. Arvind is talking very logic, and let me add more to what he says. We are in the year 2022 now. For till 2023, you will work with office hysteroscopy, grasper, and scissors. And I think is still Hager have the Shawki magic box?
Yes, I am sure.
Okay. Can we take a promise from him now? The Shawki magic box, 30% less price for Nepalese. Come on, you're a charity man. You are no. You're a charity man, Mr. Rakesh. It's a humanity. It's a humanity. Okay, 30% discount for Nepali doctor. It's a box which has like a bag. You have scope, sheath, grasper, light source, and mini camera, I think. So you have everything for your office, which can satisfy 80% of your practice. No more blind DNC, no more biopsy, no more blind IUCD extraction. If I have time, I show you how it's very different. I will not, it's different when you go and grab it by the, I received so many cases referred to me that doctors tried to remove IUCD and they fed up. They go by the tentacle, by the crocodile forceps, and sometimes they perforate and patients scream from the pain because you have to put a speculum, you have to grab the cervix, and you go by these things blindly. And when you go blindly, you hit in the walls. But if you go by the hysteroscope, patient doesn't feel any pain. The telescope diameter is the same like the IUCD insert. And you go, you see the threads, and you take it out. So from year 2022 to 2023, you will play with this thing. Shawki Magic Box with a discount of 30% to all Nepali doctor. And then you start to play. After 1 year, you buy the mini resectoscope. Yes. Well, there is no a guaranteed hysteroscopic procedure, but I developed the bubble test. I can show it to you that we inject bubbles and create this balls which go from the tubal ostium. Also, I have, if you give me time for my lecture, I will show. I inject methylene blue and you see it flowing. And when I was trying this test for the first time, I demonstrated in the hospital of Dr. Rita Bakshi in New Delhi. I tell you how by chance you discover new things. So I injected the methylene blue and it went very, not every time it's nice. It went very nicely through the ostium and everybody was applauding. Wow, beautiful test. So now this is an evidence of tubal patency. And while I was going out, the pressure decreased. I saw the dot coming back, which means there was a tubal obstruction, distal obstruction. And so it can diagnose ostial patency, but not fimbrial patency. And I have very nice test. I wish, bring my computer. The driver bring it out. So as I tell you, and please take his phone number. No, the driver brought it up, I think here. So if you buy this magic box, you have it your own. And by the way, laparoscopy equipment, you use it in the hospital. It belongs to the hospital. But hysteroscopy, it's yours. It is the toothbrush. You know, the toothbrush, you cannot use it with others because the telescope tooth is very fragile and usually multiple use will damage it. You'll not see anything. The toothbrush is the scope and sheath. The toothpaste is the pump and the camera and the light source. So you go to the hospital with this toothbrush and you take the toothpaste from the hospital I'm going to use your camera and your light source. And when you work more and more, you become rich. Then you can buy your own camera. You can buy your own tower. Where is the audiovisual person here? Audiovisual person.
There is an RQC, so there are AV malformations and also.
AVM malformation is catastrophic. I always have a problem with the old cables. So you have the connector. AVM malformation, it has to be diagnosed very well by ultrasound, because if you go by the whether DNC or hysteroscope, you will face torrential bleeding. So there is no treatment for it by hysteroscopy. The only proposed treatment is embolization, radiological guided embolization for the uterine artery. But now there is a lot of talk and indication about using hysteroscopy, Mr. Agnihotri, for retained products of conception. You're a genius, man. So when we have a retained products, you go again for curettage, definitely will miss it. The cavity is big and it's not, the cavity is not uniform, so the curette cannot reach it. But if you go under vision and you see these pieces of tissues, you use the electrode without electrosurgery. You do scrapping under vision. Regarding the test for the tube, let me, can I have sound, please, come on?
Sound you also can connect with my projector.
No, sound from speakers, you don't have?
I can connect. Just
Connect.
give me a time.
Let me show you a very nice test. Amazing hysteroscopy. I will show how the sperms travel and go from the cavity of the uterus to the tubal lumen. Definitely, I cannot bring a real sperms. And if a real sperm, you will not see it, okay? So I made a suspension of particles with little of methylene blue. So these particles look like sperm size.
So I'm connecting the audio with my projector.
Okay. But the projector speakers will not be.
It's a 10-watt projector.
Okay. Are you ready to see a new experience? Okay. Where is Naharika? Come, I want you to see this. Amazing hysteroscopy. So, Naharika, you will see how the journey of the sperms from the cavity of the uterus to meet the rendezvous site with the ovum. People naively think that the tail movement, no, it's not the tail. It's a uterotubal peristalsis that do suction. Okay? Sound? Sound? It's not coming. Sound? Okay, I will use my sound. If no, change the setting from here to here, but the sound doesn't come from here. Make the sound come from my speakers. Come, change the setting, sound from the computer speaker.
MacBook Pro speakers. ठीक है? नहीं सर पता नहीं क्यों नहीं चला.
Okay, let us try again. And go. These are sperm-like particles. Like that. And focus your eyes when these particles come close to the ostium and appreciate, is it pushed or sucked? Now we are near the ostium. Okay. Look at the, do you see the suction? Look at this. Whoop. Magical history. Again, the sperms are running. And when they come near the ostium, they are actually sucked. It is not by pushing, not by tail movement. Again. I will show you more. Wait. You will see something more now. After you have seen that magical sperm migration, you will see the methylene blue itself. Look at the suction. And now something new. That's the methylene blue, which flies like an arrow, bullseye, to go through the tubal ostium. This piece, I want to speak with Dr. Jadib about this. Look at this. This is a miracle research. The dye goes to the ovulation dominant side, which means that the suction mechanism is controlled by the ovary. Look at this. I have a lot of surprises here in this box, so give me time. Sir, Mr. Malhotra, one day is not enough. One day is not enough. No. And I took two promises. One from Dr. Jadip, that we will arrange a full 3 days program in Nepal, 1 day IVF, serial production, 1 day ultrasound, 1 day, and the other promise from Mr. Bindalji and Hager Company and his group to offer the magic box, which has scope and sheets, the basic, for a 30% discount to the Nepali doctor. He whispered in my ears now. He said, okay, I agree. He told me, yes, I agree, but with the minimum sales of certain number of boxes. It's between you and them. Okay, if you take like 10 or 15 or 20 boxes for your doctors, you know that Dr. Jude Okahama in Nigeria, they bought 50 boxes for Nigerian doctor, 50 boxes. So this is the way how
this makes it very simple. The whole packet is in one box and all your basics.
You carry it to your office,
you carry very well.
OT or whatever.
Yeah.
Can I have 5 minutes to?
Yeah, yeah.
5
Because
minutes.
till they're getting ready.
Okay, so now time to give you a lecture. Today, your dreams. I want to remove may. It already come true. Okay. For me, it come true because I met you. I don't mean you, I mean you. Okay. She smiled. Oh my God. So your dream will come true not by just sleeping, dreaming in the bed. Those who dream in the bed will change nothing except the diapers and towels, okay? You understand me, right? The dreams that will fulfill your wishes, those who come to you when you're awake, that it doesn't let you sleep. You keep the night thinking how I develop myself, how I'll be a good surgeon. So we all, not only me, should appreciate and thank this couple, okay? I always say couple. You believe as if they were born together, okay? They were like conjoined twins. And the good thing in this couple is not the skills in the profession or in science. I know them from a long time, as I have millions of friends all over the world. With these two people, I've never heard them talking bad about any person. Even with enemies, with those who wanted to, they so honest, so sincere, so focused on their lives. Okay. And I enjoy when Dr. Jadip called me brother. I feel it really, okay, like a brother, okay. I love them as a family, as a doctors, as a story of success, how they develop themselves. And I'm sure you know that their career, both of them, they were once president of the Foxy, president of the Indian Society of Infertility, president of the ISAR, menopause. And this is not because only of their skills and talents, because of their popularity and love in the heart of people. If you want to be successful, you have to win the heart. How many great surgeons, great doctors, but they are losers in life. They are not appreciated, they are not loved. Even when they say a lecture, people go out, you don't want to have a selfie with them. But I think that Dr. Malhotra, the Malhotras, had the largest number of selfies all over the world, second to Bollywood stars, okay? So if you want to learn something from them, learn the personality, the attitude. And when I put this picture, I felt that the pictures can tell everything, correct? I don't need to talk. There is a science called body language, that when you look on, this person is really good heart. This person is a snake, okay? And he pretending to be a good heart. So stay close to them and stay close to see how they speak, how they behave with each other. I learned a lot from the Malhotras in the way they behave with their daughter and son, okay? How they're so caring, absorbing, tolerating. So success is integrated. You cannot only be successful socially and loser professionally. So I'm happy and you are happy and blessed to be with them. Are you ready now? Yes. Hysteroscopy. I ignited hysteroscopy in the veins of every doctor in the world. Before, it was not interest at all. India is my biggest experience. I've been in 56 countries. With each star, we went there several times. And my team suffered a lot. My competitor here is not endoscopic surgeon. I have to impress Indian colleagues by having the same attitude and same physical structure like Salman. So I almost became Indian by genes, traveled all over the country using all airlines, spicy, non-spicy, Go, Indigo, Jet Connect. And I also traveled by trains, and this is unforgettable experience. Unforgettable. I've never traveled before in a train when there is a compartment like 4 or 6 beds. You know, most of the long distance, it's not seats, okay? And the people with you, they're strangers. So for 10 hours, you hear a musical, a diesel engine running, okay? Plus all kind of explosions happen, all right? You know, explosions, Mr. And you cannot stop them, all right? But my team is very kind. Every time Sanjay goes, sir, are you fine? Yes, I'm okay. They bring me water, they bring you food. Even we traveled by cars and we met elephants in the road. You see this car in front of us? Because we have to travel with more than 300 kgs equipment from a place. That's why they developed themselves. They could prove that we have a good product and to sell. These are the equipment carried over the other car. And even I used the auto rickshaw in some places when there were rain. But the fruit of that is meeting beautiful people, giving training, certification, making people happy, have interaction and talk with lovely, beautiful people, and then we celebrate success together. What I have shown you is less than 0.1% of our adventures in India. And I think that this picture can tell a lot of story. I challenge you if you find any single face not smiling. Bringing happiness to people by giving them confidence, by giving them motivation, by giving them skills. And that's my homeland. So I found that this famous singer from India made this video clip in my country. And I use this clip in every lecture. Arvind know that. I said, sir, they love this video. Please put it in every lecture. So I put this video in every lecture. And after that, developed a huge enthusiasm from Indians. We want to come to you. So this was the crown of my project, that I arranged a training program in a sailing cruise. That was a Nile cruise, receiving 75 Indian doctors with their wives and husbands. This is Cairo airport. And this is before embarking in the cruise ship. Do you remember this face? Okay. This lady was very nice also. I forgot most of the names, but everyone was super fantastic. And I think that man is the husband of Narendra's sister. Okay. And they posed in front of the pyramids, in front of the temples. And every day we had a color code uniform. Mr. Bindel has provided most of the sponsor of that. He made the caps. That this was in an island in the Nile. Many love stories was born in this trip. And they married this couple. Okay. And another picture in front of the temple. And in the night, we have a folklore party. This is the typical Egyptian dress. It's very similar to yours, colorful, full of glittering. And can you recognize this movie star? Okay, with the sherwani. And this was the last night goodbye picture. So I hope that this motivates you to come and join us. And if the Hager company would love to sponsor this training program, so you can find any support. So today is a carnival. And when you come to any training program like ultrasound or IVF or whatever, you have to think what values I will win. I'm going to pay. Yes, you will pay time. You will pay money. You will pay effort. What will be the payback? Will this tool have a value for the patient and for me, or only has a value for the salesman? He sells and takes the money. For the patient, no doubt, hysteroscopy has shifted the diagnostic accuracy from guessing to concrete proof. There is no more ultrasound, thick endometrium or a polyp or no. You go inside and you know, all right? So definitely the value for the patient is very great. The most common gynecology procedure done is DNC and biopsy. It's not hysterectomy, remember? Okay. Every day we have a lot of cases scheduled. So instead of putting the patient in the OT with expenses of hospital, anesthesia, no, in the office, the short septum, this I can do it in the office, but I never do in the office. Why? If I do it in the office, I cannot charge enough money, all right? But in the OT, I can. In the office, you can look inside the uterus, take the biopsy, put it in the bottle of formalin, send it to histopathology, and charge the patient. You will not charge the same like in the OT. So there is a value definitely for the patient and value for you. How much you get consultation fees? $5. How much you get for ultrasound consultation? $10. How much you get for hysteroscopy? And the patient hears oscopy means something expensive. If she goes to tandem, he will charge her $5,000, for example. Okay, I'm joking. She knows it's expensive. So if you charge $30 or $50 for the procedure, the patient will feel very comfortable. She saved a lot. So as values, definitely the future is for hysterectomy. And this is the two legs for the gynecologist, an ultrasound machine and a hysteroscopy set. Some people said, okay, I will pay money for a 4D expensive ultrasound machine. I said, no, if you are very rich, do it. Get a medium-sized ultrasound machine, and the rest of the money get you a Shawki magic box of a hysteroscopy set. And when you start working, make more money, go for the higher system. Training for hysteroscopy skills is not by lectures. I start by lecture, orientation to tell you what you learn. And then we go to the OT, and you see this beautiful face, okay? And in the OT, unfortunately, most of you, they do wrong thing, that they keep looking at the monitor like this. You will not learn, because all the skills is in the movement of the hand. So this is one training program. You see how much crowd. That lady doctor is taking picture by the mobile. The others are looking to the monitor, and nobody is looking to my hand. The only one who will learn well is this man. Okay, so shift your hand from the monitor to the hand of it. Then concept of hands-on. You remember these days, Sanjay God. They were the best days of your life. Okay. We traveled every and each little village in India. And I remember Dr. Alka Kriplani was introducing me in a big event. It was AISOG. She said, we have registered 33,000 lady gynecologists in the society. And Dr. Shawki has touched the hand of 32,000 for training. Only 1,000 waiting in the line queue for training. So hands-on doesn't mean your hand on the, no, my hand on your hand. Like I did today. When I touch your hand, I feel your muscle tone. Initially, you are very tense, and this it doesn't go with hysteroscopy. Laparoscopy, yes, because laparoscopy, the range of movement is big, but hysteroscopy, it's very fine movement, or you hit the walls. So I get the feeling from your hand and give the feeling for your hand. Hands on, to how to elevate, hands up, hands down, and then we enjoyed a lot of memories, pictures. Another hands on, Mr. Sanjay Gautam. Hysteroscopy changed my life, made me travel everywhere, India, and I received showers of, that was in Visakhapatnam. This is my wife, she came with me also. She couldn't believe herself that they throw flowers under her leg. And that was the elevator, this was Chennai, the elevator of the hospital. So everybody wants to go to the elevator, has to go through my heart. And this was Hyderabad. I think Mr. Modi, the Prime Minister, didn't have such a press conference like this, okay? All people coming to hear about what is hysteroscopy, what can it does, and this was one of the best visits. I forgot the name of the city, you know. Garlands, flowers, dinners, beautiful people, and this was one of the best. Remind me what the name of the city. No. Not Ghaziabad, no. You remember we had a scheduled meeting and we canceled it and then we went to them again. Exactly, yes. Signing autographs, meeting beautiful people. Lot of, this was the president of the European Society introducing me. He said, this man could be a crazy or a genius person. Yes, yes. When legs up, tell me, okay? PRP, okay. So, when legs up, tell me, all right? You know, Namet, when I was operating in Ukraine, the nurse was coming to tell me, I tell her, please, when your legs up, tell me. I said, my legs, sir? Legs, I should, not your legs, I mean the patient legs. So, when I met you this morning, quickly I did scanning, looking into your eyes to know where are you standing now? Are you just saying, I want to do it? Or you're frustrated and said, no, I'm gonna just watch and meet Osama and take some selfie pictures, but I will not buy hysteroscopy, I will not do hysteroscopy. Or yes, I will try, and then maybe next year you meet me and say, yes, I did it. Proud to be gynecologist, but you are using equipment since centuries. There is no specialty using instruments more than 200 years old. This equipment invented in the year 1826, the curate. And DNC is an absolutely blind procedure. That's why I call it a deliberate crime, because there is a 60 to 70% chance to miss a serious pathology. Going by a curate into the cavity of the uterus to catch a polyp is like going into a room to catch a chicken. The polyp will never be. So you have a solution. You have a telescope and sheath with the same diameter of a uterine sound. So insertion in the office is very easy. Plus, this is very important, Mr. Namet message. You have to tell all your doctors when you do hysteroscopy several times, your eyes will be able to identify what is this tissue. The endometrium is like the skin. It undergoes changes monthly, so you can know if this is proliferative or secretory or pathological. Okay. Yes.
You have mentioned also in the initial part, so but I insisted why I mentioned this histology. Now I understood that.
We are ready, sir.
I will finish the case and come to join you to see how is the patient feel before gynae examination. Sterilium, please.
And the next case होगा उसमें nobody is allowed inside. So we'll show you here.
You are a great man. Thank you. And I like your mustache. Egyptians are always with a mustache. I am the only one exception. Sterilium, please. Where is Vishnu? How many children you have, Vishnu, now? How many children you have? Only one. You're a lazy boy.
We have a laser at work. So if you can order for something, you can use the laser.
I never used before. I'm not an expert.
You are super expert.
Exactly.
My mistake, my apologies.
I miss these days when I was punching you and you punch me and fight.
Sometimes you are not in front.
Yeah. But honestly, among all of you, he was the most tolerating for me. Most tolerating. Okay. This is number 7. I lost weight because it's loose now. Have you seen the six packs?
Yes.
Should I show you the six packs? Not in front of you. Okay. Girls doesn't look for your six packs. They look for your 6 cars. How many cars you have? Okay. Okay. So once again, this is the Shawki Eagle Eye camera. The design is sleek, modern, ergonomic, ergonomic, friendly to the hand of the doctor. Every word worth a price, okay? Friendly to your hand, so you can have a control to the zoom and focus. This is a case done. Let me show off some of the quality. Look at the magnification power. Look at this, look at this, look at this. Bindel G. You see that? This is the threads of the mesh of the gauze, okay? Water on. So this is a case of a poor endometrium, and poor endometrium like a poor soil. In the poor soil, we put fertilizers, water. No, wait. We put fertilizers, okay, Naharika, and the
23-year-old primary amenorrhea, she did not get bleeding even after estrogen, progesterone, and
okay.
withdrawal. So
Primary.
amenorrhea.
Okay, close. So when you have a poor soil, you put some fertilizers to improve fertility of the land. So here is the same concept. If we have a poor endometrium, we put the fertilizers, which is the PRP. Okay, so this is the vaginoscopy technique. It's vaginoscopy this way is my technique. Remove your hand. The first description of vaginoscopy was by Italian doctor Bitocchi. It was like that. You go through the vagina and you hit the posterior fornix, you pull back and you go from the cervix. This is the popular. But my technique is different. You close the vulva, you create the space, close, close, close. We appreciate a good closure by flattening of the roget. You see, flattening. Okay. There is some monilial infection here. You see that? You see this monilial infection? If you use a casco speculum, you will not be able to see this. Another monilial infection. And this is the cervix, very narrow cervix because she's hypoestrogenic. Yeah. Okay. Look at the mucus and how we squeeze the mucus. Slowly remove your hand, slowly. Okay. Squeezing the mucus out, rotate. That's the endocervix. Appreciate the beauty of the camera. You see that? You can see the RBCs running, huh? You see this? I am cleaning the mucus, change it. Look at the how to squeeze the mucus, Dr. Malhotra. Look, like the fountains, okay? So if you do it in the cycle before IVF, you prepare the cervix and you avoid the bad cervical mucus. Okay, now I have to kursi, all table up. When I say table up, because I want to go by my hand down, but there is probably some spotting because there is a blood here. You see this? A blood here. Okay, this is the internal os. You see the effect of the fluid pressure? You see that? This is the internal os. And I want to show you again the phenomena of RBCs. You see the RBCs here? You see that? Dr. Malhotra call it the marching RBCs, okay? And then Dr. Malhotra, I think she is starting menstruation. Look at that. This is a menstruation. This is, you see how we cut adhesion? I go like this. You see how to cut adhesion? All right. Have you seen this, Naharika? Look at the adhesions, how to cut. See the adhesion? With the pressure. Yes, the fluid pressure. No scissors. I'm using the fluid pressure to go and clean the lens. Go back again slowly. Adjust the focus. Very narrow, and there is a lot of adhesions here. So I will shoot. No. Let me do it Shawki way. This is Shawki way. You look at this. Pani. Look at this, Dr. Malhotra. I think I deserve a tandoori chicken now. Okay. So we cut this adhesions. Some more here. I'm cutting and withdraw. I want to make sure if this is the rest of the cavity or tubal ostium. This could be the ostium. I'm not sure. This is the tubal ostium. How could I know? Look at the lining. Huh? This is the tubal ostium. So I should not push more than that. Okay, we cut. This is one ostia, and this is the other ostia. Some adhesions more here. You see this? Okay, so give me the scissor because these adhesions are tough. Give me the scissors, please. Where is Dr. Naharika? Where is Naharika? Put gloves in your hand, Naharika. Okay, so I demonstrated how to cut the adhesion bluntly. All right. Now you can see this is one tubal ostium here. All right. And other ostia here come from my right side. Bring the handle up and your fingers here. Okay. Just put your fingers. Yes. Is it no, leave the camera. Okay. Open, close, open, keep it open. Now, yes, rotate. You deserve a big kiss. Can I give it now? Okay. Okay, open, open. لا rotate بقى زي ما عملت كده. And cut. Excellent. Open, open, cut. Yes. When you cut, withdraw a little bit. Don't cut and push. Open. Show them how to adjust the scissor correct. This is wrong. And this is wrong. It should be like this. Okay. And cut. Orgasmic sensation. Okay. Open. Cut. Open. Cut. Excellent. And then palpate. Oh my God, you are better than me. Open, cut. The cavity is really expanded. Open, cut, palpate. That's enough, okay? So now open, cut, open, no, no, yes, like this, cut, open, again, cut. This is not the best. You have to go a little bit down. Open, rotate, cut. Excellent. That's enough. You see how much expansion done? Okay. Now leave this part for me. Laterally, I want also to expand here. Okay. So yes, I'll go like this. You see that? And cut. And cut. You see the expansion done? Exactly. Shoulders is better now. You see that? Other side also. Give me the PRP. All right. The endometrium is very poor, as you see. So what we will do now is to prepare the PRP. Can I hear an applause for Niharika, please? Thank you. Thank you. All right. Now we use the ovum pickup needle, the same one that Dr. Jidip used for ovum pickup. You see that? And the beveling. And I choose an area which has some endometrium like this one. And I go like this and strictly, you see, subendometrial, inject half of it. You see the swelling? It's swelling here, all right? Half. Inject. When you inject, keep on, don't pull back because it regurgitates back. Yes, inject. Keep the pressure. More. 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 Okay, enough. And then I choose this place. Inject. Yes, you see the swelling? You see the swelling? Okay. And then the last one, we give it here. Same like subcutaneous injection. Okay, you see that? Inject all of it. Excellent. Okay, and then we go out, we close and the cavity collapse, collapse, collapse. Thank you very much. Thank you very much. PRP has proved a very rewarding result regards endometrial growth. And let me tell you the story of PRP. So I'm really glad that most of you had this experience of hands-on and to feel the range of movement of the hysteroscope and how much gentleness you need in rotation. And most of the movement in laparoscopy is side to side, up and down. That's laparoscopy, okay? And use your shoulder joint. But in hysteroscopy, all the movement is from the wrist and it's rotatory movement a little up and down. So till the time you change the memory from your shoulder to your wrist, it will take some effort from you. PRP applications in medicine are many. They use it very, very frequently in the face. They inject it under the skin so you look younger. And they use it also in the knees for chronic arthritis. Even in ophthalmology, it has application in many fields. As Dr. Malhotra said, it has some growth factors which help regeneration of the epithelium and the cells. And also it has like vascular growth factors, which brings new blood vessels to enrich this area. And all this is fertilizing factors to improve the tissues. The first application in gynecology was published by injecting PRP or infusion of PRP intrauterine, same like IOI. and they reported a good improvement of endometrium and higher implantation rate. I like the idea, but I wanted to work better. So I thought if the cosmetic people injected under the skin of the face, so logically, if you inject the PRP under the endometrium, it will work better. I am sharing this story to teach you how to think, how to reach solution. So my challenge, how to find a needle that can I go through the hysteroscope. There is no long needle. So actually it was the idea of my son. He said that our friends in the next room, they do IVF, and I saw them, they have long needle for ovum pickup. Let me bring it and try. Okay, the first one we used was short. It cannot go from the long sheath. So we changed the sheath, and then we had the proper needle that can pass, and you can see it very well. And the first case, I applied PRP subendometrial with a patient referred from IVF center to me. Very poor endometrium, failed IVF 4 times. And she was coming from Saudi Arabia, very rich royal celebrity, okay? So she was referred only to do diagnostic hysteroscopy because of failure of implantation. So when I did hysteroscopy, the cavity looking normal. I didn't find anything. So I thought to add something new, and I did this subendometrial PRP. When the patient came from her room to consultation, I showed her the video. I did blah, 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 blah. And we will charge you a little more because of the PRP. The patient burst into anger. And she said, I didn't consent that you do experimental work on me. And that's unethical. She's correct in a way, all right? And she was very angry. And she left the hospital. And next day, the IVF center called me to say, sir, you caused us a big trouble because the patient refused to continue her therapy in our country, and she left back. So I felt frustrated, actually, and no appreciation from the patient. After 3 months, the IVF people called me again. We have more problem. The patient is raising a case against us in the court, claiming that we did an experimental procedure that destroyed her uterus. Somebody told her, she went after 3 months for consultation, and she complained of secondary amenorrhea. So she told her, most probably an Asherman, because of what they did to your uterus, they injected material, blah, blah, blah. And now there is a big case, and they're asking for huge millions compensation. I said, okay, let us prepare our papers. I want her to do FSH, AMH, and to do an ultrasound. And then came the surprise. Single living sac, 10 weeks pregnancy. And that was the cause of amenorrhea. And I received a gold Rolex watch from her. So this was the first experiment, and I was so happy. So in the first conference, I told the story, and I said to the audience, I'm very proud to say that my results in PRP pregnancy rate, 100%. Come on. Yes, it was only one case. And but later on, my son Yahya had his MS thesis about PRP to improve endometrium. The study was to inject PRP, but we will not wait for pregnancy. We do follow up by ultrasound to measure endometrial thickness. And all cases, they have very good endometrium. But we have to be careful. It's not necessarily the good endometrium because of the PRP, because when you inject the PRP, there is some edema. So we saw very good triple line endometrium. So time will show the value of these procedures in terms of pregnancy rate. So this is another application. If it is really useful, I think you can do it in your office for any patient with, you call it unexplained infertility, poor response, poor endometrium, old age, previous history of Cox infection, tuberculosis. One patient like this, I think the cause here is Asherman. You have seen the adhesion. You have seen how nicely Niharika could cut. But this kind of Asherman is really challenging and dangerous because the uterus is already hypoplastic, very thin myometrial wall. So if you cut much, you can perforate. And to tell you more secrets, we were about to perforate on the left side, but you didn't notice that. It doesn't happen, perforation. But I knew that one more cut will perforate. How? If I play the video back again, you'll see the color is white. When you come to this angle, it becomes blackish, which means it's very thin. So you have to stop. Maybe Niharika is, if alone by her own, she will continue cut here, right? So hysteroscopy also has the character of tissue structure surgery. Your eyes should differentiate between muscle, fibrous, endometrium, okay? And this is by the eye and by the sensation of scissor cut. When you cut, you feel the resistance. How to learn this? By training, by trials, and then you will get it. So till now we are in the middle of the day, and I'm happy you have seen plenty of septums and you have seen a nice Asherman. Did you like the dissection by hydrostatic? Okay, it requires a high pressure and tactile sensation. Also, I was about to perforate, but you didn't notice that. I like to speak about my complications also. It doesn't happen, but when I was pushing into the synechia, all right, the color is white. Muscle or fibers, they look white. So you don't know when to stop, all right? So it is not only the fluid pressure, it's the gentle push. So how to feel to stop or not. So long it's gliding with little resistance, so I'm in the adhesions. When the resistance turns to be more strong, you are going into the myometrial wall. And that's what happened to me. I felt I'm near the myometrium. I turned the camera, I found the tubal ostium. So that if I keep pushing, you will see the bowels, all right? Complication didn't happen, but I tell you how it may happen. So I pulled back, and then I decided to use the scissor here. Because if I keep doing the same technique with a thin muscle wall, it is dangerous. These are the gems and the pearls you learn in the workshop. Not only to tell you cut or resect, no, this little. When I say table up, because I want to push my hand down. When I said more pressure, when the cavity is collapsed. Okay. I wish we finish in time because can I follow my project? So let us share together the experience of a patient when she came to your office, scared, frightened, panicked, and then you enter the room with old instruments like that. It's scary. Put yourself in a position of the patient. And when she hears the clicking, clicking sound, and she is, look at her face. Sir, what you will do? Shut up. Open your legs. It's very rude. We are very rude, really. There is no examination in medicine with such humiliation to let the patient lean her back, open her legs, say, please come in. Come on. Yes. And sometimes it's very difficult for the doctor to examine the vagina when the patient, I don't think you have this character in your country, but in my country, we have the elephant size, all right? So the buttocks of the patient are like this. So when she's sleeping and you want to put the speculum, madam, open your legs. Sir, I'm opening maximum, but there is no space, okay? There is no space. So if you have a telescope, you stay away from her and you put it like, you don't have to come close. You don't have to look at her even, all right? And the patient is embarrassed. And when you put your ugly metal bivalve speculum, you don't see the vagina. Although it's called vaginal examination or vaginal speculum. You see only the cervix. So I'm sorry to tell you, you have never in your life examined the vagina. So that's a new concept, that hysteroscopy. Hystero is the wrong name. It's a gynoscopy. You examine the vagina. Have you seen here the monilial infection? The technique is very simple. As you see me doing it, you insert the telescope through the vulva, open the water, Come on, open the water and enjoy. That's the strawberry vagina. We always say trichomonas vagina, but you have never seen a strawberry in your life, only in the textbook. Now you see the strawberry vagina, atrophic vagina, atrophic cervix. This is a postmenopausal patient. So a beautiful technique. You enter the vagina comfortably for the patient and for you. Again, nobody can resist the lipsticks of Angelina Jolie. You can see it also in the cervix. That's a big cervical ectopy or erosion. And you can do staining and examine same like colposcopy. And rare pathology, if this patient comes to Dr. Tandon complaining of dysmenorrhea and pain, he will do laparoscopy for her and he will find endometriosis in the uterus sacral, but he will not see this. So you have to do also, I call it FDA, fluid distension assisted vaginoscopy. And look, Niharika, you can even, this cystic lesion, you can even treat. Look at this, chocolate. Same like Dr. Tandon do the endometrioma, I do from, this is vaginal surgery. So colposcopy is very popular, but the colposcope helps you only to see the outer surface, but it doesn't go inside, and you cannot see the endocervix and the Nabatean cyst and the mucosa. Vaginal anomalies, septum, like this. That's a beautiful demonstration for a vaginal septum. These are not two cervices, it's one cervix, but divided by the septum. And the old technique was very ugly. You put two speculums, visibility is very poor, you cannot see the cervix, and this is the bladder, Dr. Tandon. Your name was Amit Tandon. Amit, you see how I'm good memory? So this is the bladder, and here is the rectum. So easily you can injure them. But with this technique, good visibility. And you see both sides, and you cut. This is a monopolar. And there is no any fear or threat to injure the bladder or the rectum. You can see very well, and the septum is stretched. But using just traction by speculum is not good. This is one half. And every time I check the position of the external os. Why? Level. Okay. I'm coming then. This is, you keep on, keep on. This is the end of the procedure. You can touch some of the bleeders. Here I have to coagulate. It's not like the septum. The septum, the muscle fibers will do hemostasis, but here, and no need to take stitches. I'm now going to the cervical part of the septum. This is a complex VCU. You see that bleeders? Okay, now we come to exciting part, hysteroscopy inversions, all right? Because in my country and some cultures, hymen is a matter of life and death. The family of the patient are ready to sacrifice her neck, her arm, but not the hymen.
Very interesting case this is. So you can see she's my friend, and she has a huge myomatous polyp.
Myomatous polyp, okay.
Yeah, with vascularity, a lot of
Okay.
vascularity.
That's good. Can I visit the washroom before?
If there is a polyp,
No, it's not a polyp. It's a myoma. No evening, I go by the train.
Very interesting case now, and I'm going to send two of you inside and just to go and see. So it's a huge myomatous polyp. Okay, so can you see the image right? So we're going to do a hysteroscopy and let's see, and it's very big. Here also.
How old is the patient?
37-year-old.
Okay.
Not married,
Not married. Okay.
but plans to.
Okay, but with this big size, I think we have to dilate the hymen. Yeah. Give me sterilium, please. Prepare for me the large resectoscope as well. You have the large? 4 mm, yes.
Bada wala hysteroscope,
The large one.
resectoscope, big one.
Big one.
We have both.
Yeah. For this case, maybe there maybe not no chance for training because she's a virgin. So and it's a big mass, so you will not see well. Okay, let me try first, and then if there is no chance in this one, next case you yeah. Stay with me. Yeah. $250. Binder G. Where is pound? 250 pound. White balance done. Water on. We clean the blood from the vulval orifice and then we go transhymen. Okay, I can see the mass is very big and filling the vagina. There is a lot of blood. No, leave your hand. So we have to clean this blood first.
This makes it probably similar if you cut the pedicle and just put it out.
Yeah, but the blood make the visibility not nice. So I have to clean. Wait, I'm clean. I'm pushing like this to clean. I think it is filling the whole, this is the mass, okay? So just to let you see well, I have to clean the blood. Okay. It's really like a baby head size. This is the cervix. It's dilating the cervix. Okay. Now you can close, please. Wait. So now close. I think I'll use a gauze to clean. Give me a gauze and the non-toothed. Long gauze and non-toothed. No. Gauze piece. Long, small gauze piece. Like this one. Dry one, yes. As I told you, there's no chance to make it threaded. No. Because of the blood and the large size. Oh, it's a very big. You see how much blood? Can I have pressure is 250? Okay. I'm trying to irrigate all the blood outside, And this is one of the problem in hysteroscopy. It's not like laparoscopy. Cannot do suction here. Close now. I will be patient. Give me kursi. Be patient, and it is also degenerated. Huh? This is the vaginal wall. Vaginal wall. Give it time and be patient. This is the mass, but there is a lot of blood. This is the posterior. The patient is awake, sir. Patient move, yeah. Probably this is the posterior lip of the cervix, and this is the mass coming from here. You see that? Okay. This is the posterior lip. Leave your hand suddenly. Suddenly. Yes, I want the gush. Gush. Close again. Now this is the mass and the vaginal wall. Yes, close. This is the vaginal urethra. It will be a little bit clear now. This is the mass to one side. It's filling the whole vagina. Filling the whole vagina. So I have to glide slowly and clean to find the way. This is the lateral vaginal wall. Okay, and there's degeneration also here. This is the anterior lip of the cervix. And because it's coming from the cervix, it doesn't give much space to go in. This is the cervical lip. You see that? Okay. So a lot of blood. Leave your hand. Leave it slowly. I'm going in 300, please. Pressure, a lot of blood inside the cavity. I want to see, this is the pedicle most probably. Let me make sure. And as Niharika said, the pedicle is very vascular. Very vascular. This is the pedicle, okay. It's a huge fibroid. And maybe I'm inside the uterus. Maybe I'm inside the cavity already, because the uterus is big. I have to. I'm inside the cavity. This is the base, right? This is the pedicle, but it's a very broad pedicle. I want to make sure it's suitable for resection or no. Now I'm going into. No, this is the uterine cavity here. Yeah. This is the uterine cavity. Okay, so what I will do now, I will try to cut as much as possible. I'm not sure I can cut the whole pedicle. As much as possible from the pedicle, and then grab it and twist and come out. All right. If I put a speculum, you will be surprised from the size. Give me light, please. The larger resectoscope. Oh my God. You see that? That's it. Okay. It's very big. To be honest, it needs a vaginal morcellation more than hysteroscopy. Let me go by the larger resectoscope. No, but if I try and if I twist only, it will bring the myometrium. So I will cut whatever possible from the pedicle and then twist. Yes. So, yes. I can put 2 fingers inside the cervix. The problem now also, because of the cervix dilated, the distension will not be easy. Okay. But I feel I will cut as much as possible from the pedicle, so the rest will come by twisting. Okay. 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 Can you see it? Okay. The large, this is mono or bipolar? Bipolar, okay. At least to cut as much of the peg, so remaining will be less, so we can twist, and then we go again to see if any, because you said it's very vascular. Yeah. Yes, we will see, inshallah. Don't put the light in my eyes. Don't put the light in my eyes. Don't put. Bindal G, this resectoscope belongs to you or to the hospital? Dr. Malhotra, this is a urology resectoscope.
Yeah,
This is a urology, okay, and not very comfortable for gynecologists, and the lens is not very nice. No, is not clean or.
The lens is very good. This is Olympus.
Yeah, but. Leave it to me. No, still the lens is not good. I cannot work like this. Do you have a 4mm lens? Okay. I have a feeling it's not about cleaning. It's the camera is okay. Maybe clean the distal part. Now it's better, I think. It's getting better. Clean this. Yes. No, with betadine. No, it's hazy. You see that, Dr. Malhotra? Okay, I have another solution. If you can, we try to put this lens. Put this lens.
One more.
All right.
Because this is being used by lots of scopes.
It's a very broad base, very broad.
You can feel the pedicle.
I can feel it, yeah. And the problem is very low.
Yeah,
it's very low. So if it is high in the cavity, I can reach it better. Yeah. Let us have a look and decide what to do.
Yeah, this is better.
Okay. As I told you, because if you want to twist a very broad base, it will pull the tissues or can invert it. But if we cut most of it, it will avulse easier. Okay. Pressure is 350. This is the water. Better, yes. Okay, you hold this. Okay. Yes. Is it working? It's okay. All right. Water on.
Mission impossible.
This is the vaginal wall. You see that? This view is very nice. This is the vaginal wall. This is the cervical lip, and this is the mass. You see that? It is from the cervix, not from the uterus. So this is the pedicle, okay? So I have to. I have to decompress it. Here, see that? I'm decompressing the base, but by the way, also have to be careful because the wall of the cervix is very thin. It's not like the uterus, huh? Don't move. This is the pedicle here. See that? This is the part I took from the pedicle. I have to think to take more or not. Yes. Let me check. Okay, this is the rest of the cavity here. Okay, so I do like this. Yeah. It is actually doesn't give me a space to move because it's filling the space, you know, the vagina and the cervix.
You see those glands, you make up those.
Yes. Yeah, but I want to know where I am. It is here, the pedicle. I took this part, but the rest, I think it's like 50%. I go out. This is the cervix. This is the lateral vaginal wall. This is the mass. This is the cervix. You see how I go in, Malhotra? This is lateral cervical lip and a lot of blood inside. I will take last cut and then do morcellation. Okay. Give me now light. Light on. Light on. And you have a single tooth. This is not single tooth. And regular scissor as well. You have one more? No, patient is moving, sir. You know, it is like this, it means it's loose, okay? A little bit loose. No. I want a tenaculum, single tooth. Can you relax the patient, sir? When she's relaxed, let me know. Dr. Malhotra.
Yes, sir.
Can you check where is my laptop bag? Because my specs and bring it, Binder. Relaxed? Okay. No problem now. There is a solution for everything. But I need a single tooth so it can bite harder in the. Okay, that's good. That's perfect. Could you find my specs? You bring the bag and I'll tell you where. No, down. I will tell you, bring the bag. No. I tell you, come, rotate.
There is a pouch here. Yes. Okay, good boy. Good boy, the red one. The red one. Yes. Thank you, Bindalji. Put it in my eyes. Thank you. Perfect. Look at my ears. Thank you. You make life better now. Okay. Move this. What we cut was a small part, not a big part, actually. And it's very tempting that I put a scissor and cut. Can we have another single tooth? Another single tooth. Give me regular scissor. Regular scissor. Long. Scissors wrong. What I cut was very small part, actually. Yes. From below. Can we have another single tooth? No, it's getting another single tooth. Yes, excellent. Dr. Malhotra, this is a child baby head, not a, you see? Give me the scissors again. You have an obstetric forceps. So to know that we cut, well, this is the pedicle. You see the pedicle now? Yes. You see it? Okay. Give me another, no, another one like this. Okay, this is the pedicle. You see it? All right. No. It's in. Okay. Pull down. Okay. Much down. Okay. That's it. And this is the pedicle here. So from this, we know that we got it correctly from the pedicle. But now I want to have a look inside the uterus. No, it's not necessary. There is still some part of the like this, yes. Do you have another ovum forceps? Okay. Remove this. Hold this. Yes. Yes. Yes, scissor. Okay. And now we go to the rest and cut. Thank you. Thank you. Give me that again. Okay. I want the single tooth, this. Leave it to me. Okay. I go like this. This more down. Yes. You see the cervix is open like after delivery. Up, my friend. No, up. Yes. Yes. And hold this and relax. Leave this. Open water, please. Okay. Remove the speculum. There's a lot of leakage, so I want to. Okay, this is the uterine cavity. Okay. This is the tubal ostia, but the cavity is collapsed because we cannot achieve good distension. So this is where we cut the pedicle by the resectoscope. So there is no need for cauterization. All right, and we go out, 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 out. There is no any residual part of the fibroid. You see that? Wait, I said keep like this. Okay, let me do something more. I want to close the cervix well, so I give you. No. Okay. From that side, show me the other side here. Yes, excellent. You're an excellent man. Wait. Still, I'm closing the cervix to get good distension. Remove this. Okay. Remove this. All right. At least I'm satisfied. There is no any residual part. Still, this is the cavity. Here is the tubal ostium in that side. You see that? Yeah. Everybody now see well? Okay. And this is the pedicle here. Malhotra. Yes. You recognize now that? Yes, anterior wall, and there is no residual part of it. Okay. Yeah. Even I don't need to remove more. But you just check if it's bleeding. It will be bleeding a little bit. Trust me. Maybe. Trust me. Trust me. No worry at all. This is the myoma was here, and that's it. Perfect. Thank you very much. Thank you very much. We cauterized and twisted. Don't worry us. But the cervix is like after full-term delivery.
I don't know how it came out from the cervix.
Okay. I deserve a tandoori chicken for that. I deserve it. And kingfisher. Yes. And some dogs. And some dogs. Thank you, madam. Thank you for standing next to me. Your presence gave me more courage. Yeah. Oh, well. Hello, my friends. Thank you. You have seen a battle with an elephant, all right? No, not the DNC. The problem is it's a huge myoma and the cervix is fully dilated. So you cannot do distension, okay, the fluid. But I could hardly see the pedicle. It's very broad pedicle. With that poor distension, you'll never be able to go all around. And it's very low from the internal level of internal os. At least I'm not inside the cavity. So I cut from the pedicle hardly 30%. And then I hold it, and by the scissor, I cut. Then the value of hysteroscopy to go back again by hysteroscope to check that there is no any residual tissues. And I tried to grab the angles of the cervix to compress the hysteroscope and to avoid leakage. But still, the distension was relatively enough to see tubal ostium. And pulling back, we saw that the site of the myoma polyp was clean. Dr. Malhotra was concerned about bleeding. She will have some bleeding like postpartum, normal postpartum, but not more than that. Yeah. If you suffer, more bleeding, you can put like a gauze compression in the cervical canal. But the cervical canal can admit 2 or 3 fingers. Can you imagine? So, versions. Let me show you some of the cases like the one I did now, but easy one. This is the easy one. Look at this. Where is Dr. Malhotra? Look at this one. This is the easy one, right? No, but you can see the cervical lip. Stay with me to show you how beautifully this can be done. And this is the posterior lip, some Nabuthian cysts. And then go slowly in. You see that? Naharika. Now you can see the wall of the cervix, the wall of the fibroid polyp, and look at this beautiful view. And then you will see the pedicle now. Wait. Okay, sorry, no. Look at this part. Look at this part here. This one now, and that's it. You see the pedicle? And that's an easy hunt now. You go by the resectoscope and you cut. But the one you brought me, no, it's. This is another one. Look at this. This is the cavity. And here is the polyp. You see that? This is the base. I can see the base and cut. Okay. Keep watching and cut. And third cut. And look, the remaining part is attached by very thin. You see that? You see in Harika where? So actually, it will fly away by pressure of fluid. Keep your eyes. You see that? You see that? And that's the pedicle. I can show the pedicle here a little bit like this, but it was bloody. And that's the view after. And okay. So let me show you some of the indications in versions, because we meet some congenital anomalies like Ujala syndrome. I discovered Ujala syndrome first time in my life here in Mumbai. We were in Navi Mumbai. I didn't know what's Ujala syndrome. Although I'm a professor in the university, I teach, but I didn't know at that time. Maybe how many years ago? Sanjay Gautam, you remember Navi Mumbai? It was 5-6 years ago or more. So anyway, the owner of the doctor is a very nice man. He told me, sir, we have a nice cases for you, septum myoma, blah, blah. And then it said, we have a case of 10 years old, 11 years old, young girl, severe abdominal pain. And she was operated upon as acute abdomen appendicitis. They found no appendicitis, but there was a mass next to the vagina. And then they did an MRI and we realized it is a very rare syndrome called OVERA or Herrlin-Werner-Wunderlich syndrome. OVERA is abbreviation for obstructive hemivagina ipsilateral renal agenesis. They have double uterus, cervix, and vaginal septum, but the vaginal septum is not in the middle. It fuses with lateral vaginal wall. So, and they have absent kidney on that side. So she menstruates normally from here, but this place menstruate into a blind pouch. And by time this collects and make a severe pain. This is the MRI, Dr. Ahmed. This is the normal uterus, which menstruate into normal vagina. And that's the uterus connected to the obstructed vagina, and there is collection of blood. So, and this is the laparoscopic view. Actually, the laparoscopic surgeon get frightened. He didn't know what is this. These are double uterus, and this is hematocolpus. The traditional treatment originally was vaginal approach to put retractors and try to cut that septum and communicate both vagina. But imagine you are doing this in 10 years old girl. The vagina is very narrow, restricted. The view is very difficult, big chance to injure the bladder and rectum, and to take sutures in this awkward place. It's not easy at all. So this was the anesthesia man in Navi Mumbai. And Namit Agnihotri was actually taking by the mobile from the monitor. And it was my first case. So I was frightened, actually. I don't know if I cut here, where I will go, into the broad ligament or what. So I started, this is the vagina, this is the resectoscope. And Aisha was closing the vagina. I asked her to release the closure to get more prominent bulge and cut. What is this? The chocolate blood. So actually, this is the obstructed hemivagina. When you cut, the chocolate blood came out. Now I felt comfortable and confident that I'm in the proper plane. Expanded this incision more, and this is the obstructed vagina. Amit, you know what is this? This is hematometra coming from the cervix. So it was a hematocolpus hematometra. By the way, where is Agnihotri? Bindal G. The case I have done now, I did the same for the sister of Poonam. You remember? Let me tell you a story about fear and cowardice, okay? I travel with them every week in many cities, and we had a girl called Poonam. She's wonderful girl, so polite, so tranquil, so hard worker. She's the one who do closure of the vagina. She said, "Sir, my sister had a submucous fibroid, and every doctor in India refused to operate." I said, "Why?" She said, "Because it is submucous and big." I said, "No, no, no, I can do it. Bring me the investigation." I saw the MRI. Oh my God, a huge myoma filling the cervix. So the cervical fibroid, intracervical, it's not intracavitary. So I felt afraid. After I was showing, I said, "Poonam, we better postpone." He said, "Why?" I said, "Let us give her some iron to improve the hemoglobin." Every visit I come, "My sister is waiting, sir. Hemoglobin is 10. No, no, no. Make it 11. Next visit, "My sister, make it 13. Until one time she said, "My sister is here, suffering severe pain, and you promised to operate." It was exactly, maybe the size of the myoma was bigger than this one. Very big, bigger. But the pedicle was coming from the uterus. So when I entered the uterus, still I could create some distension. And I saw the pedicle. And I cut the pedicle, bloop, the myoma slipped into the vagina. Then came the more difficult part, how to get it out from the vagina. It was like fetal head. And I want to get it complete just to show off and not to cut it into pieces. And then it was removed and she got married. She was married already. She was married already, but she was suffering severe pain and definitely no intercourse. And she got baby after that. Okay, so now you see how drainage from the external os and recommunication and then the family celebrated and they made a crown to me. Okay, transhymen surgery can be done with, this is the hymen. So you go through the hymen and then you see the polyp. It's a large polyp coming from. Why the view is here better? Because there is no bleeding and the polyp is small. So I can, but in the previous case, it was a really big challenge. So you go inside, you see the pedicle and you cut. This is the pedicle, you cut. Keep looking. I'm trying to cut. This is the pedicle and I am struggling inside the cervix. Now I'm in the proper position to cut. Look at this view. This is the loop, but inside the cervix, it's difficult because it's narrow. And look what happened. It was only one cut. And this is the pedicle. Another case of large polyp coming from the cervix. You see that this is the large polyp coming from inside. And we follow, go in. You can see the pedicle now. You see the pedicle? You see Amit? Again, totally different view than what you have seen inside. It was battle with an elephant, all right? This is actually endocervical polyp. It's not endometrial, huh? You see the pedicle? It's all around. Observe, learn, and enjoy. You see the pedicle, Amit? Very clear. That's an endocervical large polyp. The texture of the polyp is different. And now it's all out. The polyp is out, okay? It's attached to the loop. I show it to you, that's it. You see, Rahul, in the last cut, you hug the polyp with the electrode and you pull out. And this is the pendulum myoma. It's a mini size from the one we did today. And this is, I showed you already. And this is one of my memories with Hager people that when they used to receive me, a lot of children come also. I'm a friend not only to doctors, but children and families. Fluid pressure is not only for distension of the uterine cavity, but to overcome cervical stenosis. So you need a jet of water to go through adhesions. Look at this. This is the endocervix. You see Ahmed? This is Ahmed, this is the pinhole cervix, internal os, pinhole. And there's a lot of adhesions here. So you're gonna see the same technique I used in the case with Niharika. Enjoy this. Don't move your eyes, don't blink, and appreciate the gradual, slow tearing of synechia. Slow entry under controlled vision. So long it's gliding, keep on. And then that's the internal os, and we are inside the cavity. Anterior wall, more adhesions at the ostium here. So another mission impossible, where the external os is pinhole. You don't even see it with your eyes, but with the telescope is magnified. And the patient is postmenopausal bleeding. They tried to do D&C twice, but it was perforated. Look at the cervix. Apparently, she had a history of obstetric trauma. You see that there is cervical tear. So in Mission Impossible, we call the hero of Mission Impossible. You know the movie or not? So I don't think that he can do hysteroscopy, but we called him and he said, sorry, Osama, I cannot do it. I cannot. Even Salman himself cannot. Okay, so this picture in the Oberoi of Agra here. Okay, so this is the external os. And we go slowly in. Internal os also is very narrow. If you try to go by dilator, you will perforate or make a force track. So there is a nice technique using scissors under vision dilatation of the cervix. You see that? Beautiful technique. No more blind dilatation. It's getting bigger now. More dilated, more dilated, more dilated. And then we go, this is the cavity and there are small polyps inside. Another polyp, I'm coming. This is the endocervix. And this is a big polyp inside the cavity. Okay. Okay, I'm ready. Finish all, and then we sit together time, okay? Because I have to take, let me share you some part of my life. Today is 16th or 17th? 18th of, okay. Yes, today is 18th of July. 15th of June, I had a 17 hours flight to Indonesia. Operated in Bali, then Jakarta, then fly back home, stays 2 days operating, and then fly to Morocco, another 14 hours flight, come back from Morocco, spend 3 days work, and then we have the festival Eid vacation, the only time I spend with my wife and my son. The last day of vacation, I fly coming to you, join the Legends Go Live operations yesterday and today with you. Tomorrow Patna, after tomorrow Patna, and then fly to Dubai. and then Nepal. Let's go.
Because 20 minutes you should intake the PRP.
Yes.
Otherwise, the growth factors.
Here or here? Gloves. 7. Seven. Okay. So in this case, you can have some training inside the vagina. The previous case, you see, it's impossible, you know. Yeah, mission impossible. Water on. I said you clean inside by while it goes. Water on. Water on. Can you clean the vagina, please, with the hose? Goes on. You stand in the middle, stand in the front, hold the camera like this, aim down, not like this, aim down, your hand, okay, come here, straight shoulders, only hold with one hand, other hand is free, aim down, open the water. Wait. Okay. All right, now Vishnu will close. Give me a space, please. Straight shoulders. Okay. Now you are inside the vagina, but you're not seeing panoramic view. A little bit down. You see how much? Be flexible with me. Little bit down. A little bit like now. When I leave you, you move. Count from 1 to 10 loudly.
1, 2, 3,
No.
4.
1. Huh?
1,
2. Yes.
2,
You see, 1, 2. No, steady. Yes, count.
1,
Hmm.
2, 3, 4, 5, 6, 7, 8, 9, 10.
You have to repeat this at your home. Stability test.
Okay.
Move your hand back like this. Don't hold it from here, back, so we can have a space. Madam, if you hold it like this, I cannot reach this. So you hold it a little bit back like that, okay? So we can make focus. All right. And then this is steady. Hold the light cable with the other hand. Hold it from the metal. Rotate. This is steady. Rotate this like that. Rotate to the other side, all the way, okay? Back again. Listen, when you rotate this, don't do like that, okay? This is steady. See, when I will leave you, you see what happened? When I will leave you, she always pull up. Keep like this. Yeah, keep like this. Steady like that. Yes, now you are better. All right. And then a little move. Take it from my hand. Little move. You enjoy that?
Yes.
Like the pilot moving the wings.
Yes.
Now I am trying to rotate you and you are stubborn. You are making like this. Rotate with me. Yes. Do you feel yourself?
Yes.
You are much better now.
Yes.
Rotate. And then to enter from external os, look at the anterior lip. More down and inside. Next, doctor. Welcome. Hold the camera. What's your name? Romani. Stay in the center. Romani, straight shoulders. Yes. Take a deep breath. Yes. Relax your hands. Okay. And now rotate. You see that? A little bit down. And rotate. Now, this hand is steady. Hold the light cable by your hand from the metal. Rotate the light cable only. And this is steady. Yes. More. Upside down. More. Bring your hand toward the ceiling. Yes. More. You see that? This is the posterior wall. And then you see how she's showing a beautiful vaginoscopy. More. Okay. Rotate back. So after examining the vagina, look at the anterior lip. Yes. You are afraid to hit that, but this is correct insertion. This is wrong. You see that? This is wrong. Now, like this, and don't be afraid. Excellent. You are very good. And you are in. Last, doctor. Everybody done? Okay. Hold the camera. No, 3 doctors enough because we are taking much water. Okay. Hold the camera. Hands down, more down. Pull out little bit. Stay like this. This is the panoramic view. Hold the light cable. Rotate. When you rotate the light cable, don't move like this. This is steady. Rotate the light cable now. More. Upside down. Upside down. Opposite side. Yes. So imagine if you are inside the uterus, you can see the lateral walls and you can see the tubal ostium. Okay. Bring me to the other side. You did or not? Oh, you're not with us. Okay. What's your name?
Sudha.
Sudha is the most lucky doctor because she will touch my hand. Read this. No, madam. Only touch my hand. Don't try to drive. Take the feeling from my hand. You see this movement?
Yes.
Nobody can see it. I am moving now. I am moving, but you cannot see it, but she feel it. All right. So you will take the fine touch from my hand, and then I go down in. This is the endocervix. Release your hand, Vishnu. You see going slowly. This is all endocervix. It's enjoyable trip. And no. What is the obstetric history of this patient? Tell me. What is the obstetric history? Uterus is RVF. Again, adhesions here. Leave it to me. There are adhesions here, closing the internal os. Give me stool. That's an example of internal os. You see the internal os here, but there are adhesions, okay? Give me scissors, please.
She's a case of secondary infertility.
Yeah,
She
but
has
there are
one-
adhesions here. You see
Yeah,
that?
and she has severe oligomenorrhea and very irregular cycles.
But-
So she's going
But you didn't tell me all this story. You said PRP. PRP. So this, it is not PRP. It is severe synechia and also retroverted uterus. Take the legs, babe. So I was trying to let madam to go, but it will not be easy. I don't see a cavity so far. I want to have any clue. I see little clue here. You see that? You see this little clue? Yes, this is a clue here. All right. So you see how I use the scissor to dilate? But still, it is very narrow. So I will see if any hope for what I'm doing or no. I'm going into a space. That's it. Okay. It's very atrophic. You see that white? It's very atrophic. and the remaining cavity is very minimal. So I will try to expand more. Yes, take the legs, please. This is what all she has. A very tubular cavity, very restricted. When the shreds come, okay, very fibrotic. I have to check. I want to make sure that I'm in the proper direction. This is the cervix, okay. And pressure 350, please. I'm increasing the fluid pressure. I want to get, this is the end of the cavity, see? There is no more space. There is some pinkish tissues, some little pinkish tissue. That's why she has scanty menses. I'm trying to release more of the adhesions to get access. Okay. All right. So unfortunately, you have to exclude tuberculosis, Dr. Malhotra. Look at this. These granulation tissues, yes, this granulation tissues is suspicious. And the cavity is very tubular. This is what I could create. This, you see that? Let me expand more. Do you feel what I'm doing? You have to exclude tuberculosis. You see, this is what she has. This is very fibrotic cavity. And this yellowish tissues is some little endometrium. You see that?
White and yellow, you see two colors?
Okay.
Yellowish and a little bit of red.
Okay, and I don't know where is the end of the cavity, so I cannot cut more. Uterus is RVF. The magic is in this step, because I could reach one ostium. You see it where? This is side, yes. Okay, this is one ostia here. It's the blessing of. So this is the cavity created now.
Going to be operated by Osama. They are very much.
Your expectation. Oh my God! Oh my God! This is the blessings of the Malhotra. Malhotra, I deserve an honorary membership in the Foxy. I deserve. So this is one tubal ostium. You see that? Okay. Yes. Yes. This is the end of my dissection. I cannot dissect more. I'll just take one like this, one like this. Okay. This is tubal ostium is here. Right. So let's see if any hope on the other side. So this is my rep. Vishnu. Every now and then. Okay. So I actually, during my insertion, I had a 50% feeling that I will fail. But now this is the other side. No, it's good. It's good. Good. Yeah, it is. Oh my God. Look at this. Look at this. Anybody wants to kiss? Okay. Okay. Where is Jadip? Where is Jadip? So now, Malhotra, I want to cut this lateral wall adhesions. You see that? No, the magic is finished already. All right. So I have some distance.
This is too good.
Actually, these are the cases that I should do in the legends. Legends go a bit. They didn't even, actually, your case is much better.
People can do still after little learning.
You see the cavity now?
Oh, beautiful.
Thank you. Thank you. Madam, you make my, this is Jadip? No, no. Okay, you see that both sides are good. So Malhotra, I think to put a balloon in this case. Everybody's happy seeing the ostia? All right, this is the ostia. Now we have a nice cavity. You see the difference between the start and the end? Okay. Okay, give me the PRP. Dr. Malhotra, I will inject the PRP subendometrial. I will put a balloon, and you can use the balloon to inject PRP through the balloon later on, okay? Intracavitary, okay. Okay, so this is the needle. There is no healthy tissues at all. Inject. You see the, do you see the swelling? It gets swelling here, okay? Inject half of it more and keep pushing, okay? Stop pushing now. All right. Let me inject. Look at this, look at this. Inject all of it, all of it, all of it, all of it, yes. Okay. So, bubble, yeah, maybe it will go next time. Okay. Now, give me now, are we recording these cases?
Yes, yes.
Okay. Naharika, for this case, I deserve something from you. Please come. Please come. Give it here. Thank you very much. Narendra, bring more cases, please. Okay. Give me now fully the one bigger than the pediatric.
Number
8. 10 is good. 10 is good. Now give me a retractor.
Another difficult case.
No, this is the crown of the day. This case here, crown of the day.
Crown of the day is the last.
No, the next one.
No, I'm happy like this. Don't put something frustrate me, okay? Anyway, sometimes it's good to fail, so you keep your ego down, okay? So give me a retractor and no, I have to put it. I have to put it under vision. I want to show them how to put, yes. And some dilators, please, also. Now, this patient had good chance because there is some islands where the endometrium cavity size is good. Retractor. Can we have table up, please? Please, can you put, where is my specs? In my hand here in my pocket? Yes. Open, look at my ears, and thank you. So this is the anterior lip. Some dilators. And another tenaculum. Open the catheter and show me the size. This is 8 or 10? 8 is good, all right. But this is not Foley's. No, but Narendra, where is the balloon? Okay, but
No, this is not. It is Foley. It's a silicone Foley.
yeah, but the silicone we cannot trim it because if we trim it, there will be leakage. It's okay. It's okay. It's okay. Give me the syringe with saline. This is saline.
Yes.
But for this, if I cut here,
You can cut.
no, really?
Yeah.
I think that the silicon will leak.
No.
Let me try. You see that? I told you. I told you. You pay for it, okay. Standard fully, yeah. I need another tenaculum. We leave the Follies for 10 days. And there is a new article now that you leave it 10 days, you remove it. After 2 weeks, you put another one. Intermittent. This is the length of the uterine cavity. No need for copper T. But definitely those cases need a second look and second session. There is nothing called Asherman surgery once. The minimum 2 or 3 times. Because now I converted her from 0 cavity to 90% cavity. By 10 days, it will shrink to 50% cavity. So you expand more. I want one tenaculum. That we have a good size cavity, and I want tenaculum. Another tenaculum, because this is not. Okay. Foley is ready. The Foley has a balloon and there is a terminal part. So if, okay. Give me 5 minutes, sir. 5 minutes more. So we have to trim the extra part so the balloon will be filling the cavity properly. Otherwise, if the balloon is the lower segment, the patient will feel severe pain and she will not tolerate the balloon. She will remove it. This is what size? This is 8? Okay. Yeah, and maybe I take bigger, yes. Okay. So now I'll show you what to Ada. This balloon is not good. When it makes like this anyway, now we can trim the extra part like this. All right, there is no leakage now. Deflate. But when it makes balloon here, it means that it's not very good. We will try. Because people always ask, Ahmed, how many millimeters you inject? It depends from one case to another. So I do it under vision. Sir, hold this. What does it mean under vision? Give me the hysteroscope. Under vision is like that. Open water. Pani. To clean, no problem. Okay. There is some blood after the correction, after the cutting. Okay. And here is tubal ostium was here. You have seen it. This is the cavity, good cavity, okay? Good cavity, okay? So hold this, madam. All right, I think this is very small, but we will try. If you push the Foley and you find it going, what does it mean? It's coiling inside. It's not perforation, coiling inside. Hold this gently. Okay, you see it now, my friends? No problem, no problem. And I follow, there is some water came on the lens. I follow. You see the coiling inside? Like a snake, huh? Okay, inject, my friend, now. Inject. Inject, strong. Inject. Yes, he's injecting now. You see that? But it's the balloon material is not good. So no, compress this by your hand. Okay, you see that? But no, the balloon is not good. It's coming out with me. You see that? It should be more than this. Leave it to me. Push hard. You see when I make like this, you feel it here, all right? So you push hard like that, and then I can go out. So the balloon is at the level of internal os. No, this balloon is not good. I'm trying to push inside. Can you get me another one? Bigger size. What size is that? You see, it's 8. Bring 12. 12. Scissors. No, scissors. So we'll use number 12, please. This is better, yes. Because the small catheter, the lumen is very narrow, so the water is compressed. It doesn't fill the balloon well. Yes.
Share if you allow me one piece, sir.
Yes.
In one conference,
Hold it.
I was
Hold
there
this.
and the faculty said 2 ml only put, not more than that. Then I asked all the people, they are my friends. I asked, sir, you should ask that if the cavity is stronger or bigger, how 2 ml, 3 or 4 ml, we should go and see. But nobody was asking the question. So, like sir said, we should see.
But I'm really amazed, surprised. Who taught you these wonderful things?
Because with him, we understand.
No, see, this is the end of.
Why you are not asking that? Why to
Don't pull, don't pull.
So, but
This question is doing cavities really good.
Let me clean the lens first. Give me gauze, please. There's a lot of water came here. What is the time now? 2, okay, we have time. I think I have to move from here 4:45. You see beautiful view now of the shaft of the balloon. You can gently remove the, okay, so I glide in, hold this strong, glide in. You see it's an RVF uterus, so I have to make my hand like this. There is no space. Now I go in. You love that, my friends? You see that? At a moment, it looks impossible and then it becomes possible. We are inside the cavity now. It's a good cavity. Strong. Yes. And now the balloon, sir, you are making life difficult because the patient is struggling with me, okay? So now I can under vision Amit pull on the pull like this. You see, I'm pulling. You see that, my friends?
yes.
To make it comfortably lying. You see that?
Yes.
That's a beautiful demonstration. Have you started injection or not yet?
No.
Okay. You can push water. Okay, I know the reason now because yes, it's getting, yes. Keep pushing. Wow, enough. You see now it's fully adapted inside the cavity. All right, fully adapted inside the cavity, and I go out. The balloon will separate the uterine walls, so there is no contact, Dr. Tandon.
Yes.
It is exactly at the level of internal os.
Yes.
Actually, the cavity is small,
Yeah.
but it will not fall down. Okay, thank you very much. Harika, how many cases left?
2 more.
You said 2 more with this one.
No, the next
Okay.
one is very difficult. So, yeah, so I just wanted to actually show you the MRI. It's hematometra with hematosalpinx and smooth narrowing of the canal. So what we did, she went somewhere, they did a DNC to drain the hematometra,
They did
which was a perforation. So she came to us.
perforation.
Yeah. And when she came to us, there was complete cervical canal stenosis and a laparotomy was done to actually repair the perforation. And we drained everything. Then again, she's developed an hematometra.
Tell them the history.
Because she came with a perforation. She did.
Give your tickets copy to
Yes, keep it with Arvind. Yes. Rahul, can you call Arvind, please? Arvind. Did you love the Asherman? Yes. This is what I call it from zero to hero. It was total gluing and there is no landmark. So there is no pinkish endometrium. It was all white. The first optimistic thing is to see tubal ostium, and then we refashion accordingly. Bindal G, can I ask you a favor, please? Do you have the phone number of the guy organizers of the Legends, Sanjeev or something like that?
Yes, yes.
Okay. Would you call him now? Because he was supposed to reimburse me 1,200 the flight ticket. And now it's nearly impossible to transfer money to Egyptian banks. Okay. So tell him, would you want me to transfer it to you and you give it to me, or what or we will be in Delhi, tell him the time he can bring it to me. Dr. Nikita said 1,200. Dr. Nikita.
So why did you cut the tip of the catheter?
The question from my friend is that why you cut the tip of the catheter. The balloon is here and there is a long tip. So if I put it inside the cavity, this part will be filling the upper segment and the balloon will be in the cervix. And it will be very painful. So I want as much as possible to accommodate the balloon in the upper part. And actually the cavity is not big. The balloon was reaching till internal os exactly. If you have seen when I was coming out, it stopped at the internal os. Not every uterus like the other. Sometimes you can do reconstruction, you have only small cavity, 1.5, 2 ml. For this one, we injected about 4 ml, which is normal size cavity. I'm flying. Tell him that we cannot transfer to Egypt because the banks of Egypt does not allow this now. Hello, Sanjeev, how are you? Still not sleeping. And they tried to do DNC perforated, and then they did laparotomy. So definitely will be a lot of adhesions. And then I think perforated again, and then she started to collect hematometra back again. So to enter a perforated cavity is very tricky. You don't know where is the weak point. Wish me God luck and God help us. Okay, if you are here, I'm comfortable. Okay, yeah. I'm comfortable. Can we have a table up, please? Sterilium? Yes. This is a congenital anomaly, nothing to see from below. So, yeah, same like the difficult myomas. I always say if you want to train new beginners, don't train them on a frozen pelvis. If you go for it, you see nothing. You have to go normal structure so you learn good.
She has multiple false passages. I'm warning you.
I thought that you love me, you know. I did a fantastic work today. So anyway, so forgive me if one of them is not up to the standards, but let us try. Let us try. Amit is here and God is upstairs. So yeah, I hope. God bless. 250 and kursi. Camera clean. Ah. $250 goes. Okay, 250, please. On. Wide goes. Okay. There is no. So Niharika just informed me that she had multiple false tracks. So each false track could be like a road to lead you to wrong direction. So
Came with perforation.
خلاص, enough, please, enough. Yani. Okay, so initially she has a cervix. We are 250, huh?
Yes.
So I clean, that's the lateral vaginal wall. And we go slowly. Open sesame. Apparently the fourth track is here. There is one. Okay. Slowly, hands out, slowly. Yes. And there is no direction. Okay. Scissors. There is no opening for internal os. They say it will help, but for me, I don't think. Yeah. Good scissors, please. You see this depression? This is a false track posteriorly, and a piece of gauze. Very strong. Goes. Otherwise, the camera will be soiled. Okay. No, leave it to me. Always check the gauze, huh? What is this violet thing? Methylene blue. 350. Done. There is no opening, huh? And there is opening now. But leading to what? I don't know. All I care about that I might miss the kiss from
खुल जाएगा because
This is not the direction. No, false, yes.
दो साल में कुल डिग्री को पीरियड आते हैं अभी सेकेंडरी very high process right into the surface.
No, there is no septum. There's
No, it was when I opened up.
yeah, but this is almost no,
Now
no,
it
no.
is fibrosis. No, it must have fibros that vaginoplasty we did. I brought the cervix down. We had the complete cervix down. We put the tube for 1 month in the so that she will not close. 2 years she remained all right, but after now again.
In those cases, Narendra, I prefer to keep them on cycloprogenova, estrogen, progesterone.
She's menstruating regularly since 2 years. This 2 months now only spotting.
No, there is no space here. Because the multiple folds passages give me a wrong impression. No ultrasound, let me try here. It looks direction, but could be a false passage also here. You see that? No, it's not promising. At least we see the techniques. Now, when you see this view, you see that you know that this is eminent perforation. This is eminent perforation, all right? So you stop trying.
You're not in the cavity.
No, 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 no. No, still I'm in the cervix. This is the cervix, Narendra, all right? This is the cervix. Yeah. And this, not the direction, and this is definitely not the direction. Or maybe, so don't worry if it's a perforation, it will heal, no?
No, there is in the last ultrasound collection.
Do you have an ultrasound picture, Naharika, to show me? No, but no, it could be a perforation. This. No, no. Ah. Ah. Oh. Oh my God. You gave me the worst time in my life, Narendra, all right? Okay. Okay. Oh my God. I had a 90% chance. Naharika. Okay. And this is the site. This is the site of the old perforation. You see that? And this is the tubal ostium. And this is okay. Narendra, you have to report this to the newspaper, actually.
Sir, I made this deliberate perforation from above.
No, okay.
You brought it down to
Okay. So now we open. This was totally closed. You see, now I will open it more. Open it more. Open it more.
Balloon ready kar lena.
I think we don't need balloon because the cervix is open well.
No, but this will get cicatrized again. No? Fibrosis.
I'm removing all the cervical adhesions.
Cervix,
Did you?
will also be taken care of.
We have a good opening, huh? But this is the site of another force track, and this is the good direction, okay? All right. You see, this is the site of old perforation, Narendra. You see that?
That operation I made.
You made?
Yes.
Thank you, my friend.
I made deliberately.
From above.
From above, we came down.
Okay.
That time there was nothing to identify.
But the cavity is good. All right. We have a promising fertility-wise. And that's the fundus. And that's the fundal perforation beautifully done by my friend Malhotra. Okay. And that's... yeah. Malhotra, look, come. This is the hematosalpinx. You see the hematosalpinx? Beautiful. We'll check the other side. No, there is no from this side, but from here there is a... beautiful. So, no, not in this case. No, not in this case. Why you are doing this to me? Okay. My glasses, please.
Thank you, sir.
Thank you for giving me the chance to show off. Okay. Where is JD? Okay. No, I want a recording from all cases. All cases, yes. And then we make a compilation, like 2 minutes from each one, with the logo of Sun Rainbow and picture of everybody.
With your music.
Yes, with them it will be. Yeah. Okay. Give me now tenaculum. Balloon, yes. And I want tenaculum. Not keep it ready, but I'm not sure I'll do. I want a tenaculum. I want a gauze, dry gauze. The direction of the cervix is very difficult.
We take a long.
This part for me is more difficult than hysteroscopy, is to find the cervix by this way. Can we have head down, please, madam?
Lightning. So what we usually do in
Enough,
transverse
enough.
vaginal septum, either you see a bulge,
Another one.
otherwise I
another
take a
one,
long
another
needle
one.
and puncture it. Jahan se blood aa raha hai to leave the needle there, and with the scissor then cut.
I want another.
So you are
Sims,
sure
another
you
Sims.
are going to go in the cervix. Now this patient, the external os, the transverse septum was at the external os.
The cervix.
So we put kuch nahi aaya nahi.
Okay.
So then we went up upar se abdominally,
Okay.
and we made a perforation from the fundus,
Tenaculum.
jo dikha tha aapko. Right
Okay.
down I brought it. So I
Another
saw the
thing,
dilator
right?
pe niche se and then opened it there. And then we pulled the cervix down and stitched it with a, so cervix was very nice. Only the internal os got stenosed here. We never thought this will happen. So transverse vaginal septum is okay, but the internal os stenosis is okay.
Yes. Excellent.
और वो दूसरी साइड से
Give him an upload.
अब नहीं होना चाहिए. I hope so. और इसमें बल्ब
When
जरूर
people have
लगाएंगे हम
good
छोटा सा.
mind, they deserve to be.
Because वो क्या ना एक हफ्ते तक छोड़ेंगे हीलिंग हो जाए.
Remove this. Excellent. Okay. Give me the balloon. Have you cut the terminal parts? Here, it is not an Asherman. So the purpose of the balloon is to keep the cervical canal open. So we don't have to inflate it too much. Okay. Thank you. Vishnu, with this hand up. Okay, this is the cervix. So we put this like this. Okay, going. Okay, now you can inject 3 ml long. 3. Enough. Pull out. Okay. Everybody's happy? Everybody's happy? Thank you very much. Thank you. Where is Naharika? If I ask her how many cases left, 2 cases. Always 2 cases. Whatever you do, 2 cases. Okay.
said herself.
All right. Dear friends, did you enjoy this case? That was the masterpiece of the day, all right? Thank you very much. Let me now confess my fears and my worries. I had a 90% chance that I perforated, okay? The internal os was totally blocked. So the first cut, you don't know where are you going. I cut and insert and try to feel. And then I found a hole. When I came close, when it is very blackish, mean that the light is not enough to read, this is 100% chance that you perforated. You've seen it. So I see this black thing and I realized it's a perforation. So I pulled back. I decided to change the direction of cut. And then I tried to cut several directions. No way. So I took the risk that I will go through this hole, and if it is a perforation, I will find the excuse. It's impossible case, but I will invent any story to show that it's not a big mistake. But once I'm in, the light was enough. It was a beautiful cavity. And then I pretended that I am strong. But my knees was trembling in the beginning. Okay, good. So as you see that hysteroscopy can do miracles. And what we do by hysteroscopy, there is no other alternative to be done by other technique. In the meaning, laparoscopic myomectomy, you can do abdominal myomectomy, TLH, but what I have done now, there is no other way unless you master hysteroscopy. You'll not be able to remove the septum or to cut the polyps or to reconstruct the glued cavity. And in the past, you used to do blind dilatation, and for the Asherman and curettage, definitely they go into false passages. And this case is an example. They went 2 times 4 passages, 2 times perforation, hematometra, because every time they perforate, infection happens and the cervix closed. So the blood collects. Now, after we opened the obstruction, dilated the cavity, and put the balloon, give her a chance, re-epithelialization will happen, and she will resume normal menstruation. Okay? So, how many cases left now? 1. And what is the time? Okay, let me try to remember the names and the city. You are? Roman from? Bangladesh. Dhaka? Dhaka. 10 times invited, but I couldn't go, no. I couldn't fly because it was the COVID time. But inshallah, we'll come to you. And?
From Prayagraj. So you came to Prayagraj once, but I couldn't.
From?
Prayagraj, Allahabad.
Ah, yes, Allahabad, yes.
So you came once over there.
Yes, I came Allahabad maybe 10 times or 12 times. Allahabad near Kanpur.
Yes.
Yes, I remember I traveled by car, Allahabad, Kanpur. Say hello to all my friends there. And you? From Agra. So you are like Mumtaz Mahal, Maharani. If Shah Jahan was still living, he will build another Taj Mahal for you. If he's still living, if he saw you, he will build another one. And you?
Dr. Ila from Agra.
From Agra. Yes. So you know my friend Dr. Al-Kassan? Yes. And her daughter is now grown up, I think? Yes, good. Manisha from Agra. You are my friend. You are my friend. You stay in the left ventricle. Okay. Which city in Nepal? Kathmandu. From? Mathura. How far from here?
1 hour.
Ah, so it's not far away. And you? Nepal also. Benderji, an honest man gives a promise, he should do it. And you're an honest man. But he will do the homework, the rest is yours. You have to, when you go back, to find a hospital with some organization to welcome the Rahul and Rakesh, to send them invitation to come to you. They will bring the equipment. Okay. You will not pay anything. No registration fees, Mr. Bendel. Mr. Bendel, I say no registration fees for Nepalis, okay? And 30% for whatever they buy from the measuring board. I will stay with you 3 days, hands-on every day. And your homework is try to collect as much as possible cases. But please, for any training program, bring normal, not normal, I mean infertility, polyps, DUB. Those cases is good for training. You cannot train a beginner on a frozen pelvis. He will get lost. So first you have to see the normal cavity, the normal insertion, and step by step we do difficult cases. I always say difficult cases is a show off, to show that I am a good man, but it will not help you because the anatomy is not normal and you will not go for these cases now. Like yesterday in the Legends Go Live, all the laparoscopies were terrible cases. Open the bladder, cut the bowels, and so who will do this? So nobody will do this thing. So you'll not enjoy it. It's good to show off like the case I did now, but nobody in the world can do it this one. Okay. So bring normal cases. Diagnosis?
She is previous to IVF failures, and she, whenever we plan her
PRP?
transfer, no, whenever we plan, she gets interventional spotting in between.
Okay.
So she has already undergone hysterolaparoscopy and polypectomy 2 years back. Both her IVF were done in Delhi.
So tell me, can they give me a flash drive with all
the recordings?
With the recording today? But because usually they say it needs time, push them to make it quickly. All the cases.
How much fluid should be inserted inside the cavity? So how much normal saline should be inserted inside the uterine cavity?
You mean the balloon?
No, sir, not in the balloon, sir. While we are doing the hysteroscopy, so there is any limit, like how much the fluid should be used?
This is an important question because the real only complication in hysteroscopy is the fluid overload. So her question, how much fluid we can put? It's not about how much fluid in, it's about how much fluid in and out and the deficit. You see, many of the fluids come in the bucket. So the deficit is the fluid went into the circulation. If you are using saline, it is safe if the deficit up to 1.5 to 2 liters. Okay, because saline is isotonic solution. It has water, electrolytes, the same like blood. If it exceeds the limit, some little pulmonary edema will happen. But glycine is only fluid. There is no electrolytes, non-electrolyte solution. If it goes into the circulation,
there are a few questions from the audience.
Okay. If it goes into the circulation, hyponatremia will happen and death. So for saline, you are allowed to accept up to 1.5 to 2 liters. For the glycine, it's 3/4 to 1 liter is maximum. So let us see the question. Platelet-rich plasma, patient. What is the pressure setting? I just mentioned it several times, but people keep asking the same question. There is no pressure settings like laparoscopy when you say put the machine to 15 or 16, because there is many variables in hysterostomy, the leakage from the cervix and the size of the cavity, the leakage from the tube. So this all can decrease the pressure. The numbers seen in the machine is not the one inside the uterus. Inside it is much lower. So the cavity can be expanded well for a pressure inside the uterus 70 to 80. Okay, more than 70 tubal spill will happen. But again, I repeated 100 times, the pressure inside the uterus is far less than the pressure in the machine. So in hysteroscopy, you start by like a pressure of 100 and you check the situation. You missed the best case in my life. Okay, thank you. So you start by 100. If the cavity is properly expanded, go on. If not, you can, sometimes the machine of Mr. Bohr's Hager can go up to 400. Sometimes we are 400 and still the cavity is not expanded because of the leakage. So the intrauterine pressure is dynamic and it's not one number. Another PRP, and then you can have lunch altogether.
find anything much, but
Mm.
she has had multiple IVF failures elsewhere.
Endometrium gross.
She had grade 4 endometriosis a long time back. She got
Okay.
operated. We frozen embryos, but every time when I start preparing her, or even she starts getting intermenstrual
Spotting.
spotting
Mm.
all the time. So
Uh-huh.
we
Sometimes
have put
the
her on-
disordered endometrium is the reason
so
for
I
that.
basically wanted to sort of,
Okay, so
so
diagnostic.
she just walked into
If
it.
if
She was not
no
sort of,
problem.
kept for the
We will start diagnostic. If there is something, we take a biopsy. Yeah. And do you prepare PRP for her as well? No. Okay. All right. So in that case, I prefer to take an endometrial biopsy also.
If you want, we can prepare PRP right away. Huh?
She can, no, she will do it later by herself. I think you learn it very well, huh? Actually, I praise your operative list. It's much, much stronger than Legends Go Live. Really, in the Legend, they gave me only one case of Asherman. It was nice, but only one case. But here you have varieties, 3-4 septums and the huge myoma and the Asherman. Yes. Yeah.
Even this one also, yeah.
Yeah. Mm. But that myoma, the pedicle was very broad. So if I start twisting from the beginning, it would avulse the cervix. Yeah. So this case, okay. This case is an IVF, and she suffers irregular spotting during preparation for embryo transfer. So we will check the endometrium. Water on 200. 200. Okay, I'm cleaning. Open the water. On. So, madam, what's your name?
Salma.
Salma? Where are you from?
I'm from Nepal.
Salma is an Egyptian name.
Yeah.
My ex-girlfriend was Salma. Okay, actually, before my wife. Yeah. Good.
Tell my wife.
Okay. No, she knows. She knows. Okay. So you go in. You are very much outside. You go in. Hands up. Give me a check. Don't always touch the vagina. Yes. Let me adjust the focus. Hands up. Hands up. Like this. Okay. Look at her hand. How much up? Because the vagina is a downward slope. But don't much up to touch the posterior wall. Stay like this. And then rotate. No, Vishnu, you're not closing well. Vishnu is tired at the end of the day. Yes. Yeah. You see now, but you see when it closes well, the cervix is pushed back. And now you rotate. I can see some bleeding coming. Look at this. This could be a dysplasia, right? One lateral vaginal wall, other lateral vaginal wall, and then hold the light cable, rotate. Vishnu, be strong. Hold the light cable like this, okay, and rotate it upside down. Lateral wall, upside down, posterior wall, other side, more. You see, sometimes you see this band in the vagina, okay? It's causes some coital troubles. Okay, next, doctor. Hold it with your hand. Okay, steady. Now the steady test. I will leave you here. Don't blink. Count loudly from 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
You are the best in the day. Yes, your friends said 1, 2, 3, 4, 5, 6. Okay, you're very stable. All right. Now hold the light cable. Rotate it upside down. Yes, more to the other side. Yes, more. Excellent. And because you are the best in the group, you will do the insertion. Okay. All right. So because this is the 30-degree lens, so the lens is looking up. So when you move to the cervix, you'll be seeing only the anterior lip. If you change the position like this, you will see the cervix in the center, but your direction is down. Look, now the cervix is in the center. If we try to push, you see, you go down, right? That's the confusion. So leave it, hold my hand. Okay, you look at the anterior lip. Don't worry, you will not hit it. You are going directly from the cervix. Adjust the focus. Endocervix. You see the vascularity, my friends? And follow the tram line. There is some blood. Dr. Jadip, any history of cesarean section? No. I can see some granulation tissue here. You see that? It's like a polyp here, you see. There is multiple polyps here. You see that? So it's a shame. It's a shame in the center of the best ultrasound in the world. Okay, these are polyps, you see, and the polyps are blocking the internal os. So I will try. You see the base of the polyp? Another one. But actually, it looks like coming from the fundus. And she has also an arcuate uterus or a short septum. You see that? What is the pressure? No, I think I will, this is the secretory endometrium. Glands, okay. But you see the polyps now. Give me the resectoscope. Because they are very fragile and spongy, the scissor cut will make them phrase out. So, yes, I want a resectoscope loop. Small, yes. And can you mop the water here? So by this, you see everything in hysteroscopy. The polyp, the septum, the myoma, the Asherman, the PRP, and now you see resection of a polyp. So that's all. Let's go quickly, please. What is the time now? 2:30. So your driver Israel said we move 4:45. 4:45. Okay. All right. So, mashallah, how many cases we did? 10 or 11? 9, good. The small one, huh? Loop. And also 2 tenaculums, just in case. One more. Can I have a kursi? Pani.
वो लगी हुई है उसमें तो पानी भैया पानी बंद कर दीजिए ये टेबल लगानी है पानी हाँ और क्या
Clean the lens. On the right side, please. Thank you. What is wrong? Not the same size? Actually, we become happy when you find a reason for the complaint. Because Dr. Jiri said, I'm frustrated that she's always spotting polyp. Yeah.
She's gone through a lot before she came to me.
Okay.
She was going around.
So that's another proof, live proof for the value of hysteroscopy. Yeah.
So in the morning when she came, I said, "No, let us do a hysteroscopy." She wasn't prepared for hysteroscopy today.
Good.
But I just said, I said, "No, let's do it."
Give her a copy of the video to know what.
Yeah. Because I suspected it last, I think 2 months back. Then she went for a shoe fair to Italy. And she took a break of 2 months and she came back.
Actually, infertility and IVF patients are more prone to develop polyps because they received a lot of induction and more estrogen secretion, and that stimulates the endometrium. Yeah.
Did egg accumulation because she's very poor result.
Yeah.
Just 4 embryos right now, and I don't want to waste that before looking at the cavity and putting them. So I said I would transfer.
Retractor, Sims, please. And all table up. All table up. Thank you. Light.
Light.
Good. Yes. This. Usually we prefer to remove polyps in infertility by scissors, because if you do much of the resection, you can cauterize the endometrium. But I'm using mini electrode and bipolar, which is very safe. Hold this. Fluid pressure 250. Remove, leave this and this. Hold this. Yes. Pani. Okay, so now we go back in again. Clean the blood. This is one polyp here, you see it? That exactly at the level of internal os. This one, huh? Okay, clean. All right. You see, this is the pedicle now, and that's the basal layer of endometrium. So it will grow back again. I have a desire to correct this, Dr. Malhotra. What do you think? Okay. It's obviously a short septum. It's a short septum, okay? And the polyp is taken off, all right? Okay, put the knife, please, for me. Knife. All right, knife. The electrocautery machine here belongs to the hospital or the board's people? This is yours? Here? Okay. The loop is for the polyp. The knife is for it's a short septum, definitely short one. It was more obvious when I used this because this machine, the tool, it gives more fluid pressure, so the tension is better, so I can see it. You definitely know the difference between monopolar and bipolar. Monopolar cut, coagulate, and spread laterally. So it's dangerous if you're near the ureter or the bowels, and it's not good for the endometrium because the area already cut, there is some thermal spread to the adjacent endometrium, so more damage in the endometrium. The bipolar only effect in the area touched. And when I cut the polyp, I didn't go very deep to the muscle layer. If you go very deep, the basal layer is destroyed and regeneration will be back. Remove the polyp, only the basal layer is intact. The value advantage of this mini resectoscope that you can go without dilatation. As you see, no need for dilatation, yes. Pressure is 200, no. You have to check now. You see the knife has some tissues on it. So this will not cut well. And this is not good, Mr. Vishnu. Actually, you were entitled for $200 bonus. Now you will pay $50 penalty. Fine, yes. Clean again. Okay. All right. Pull up. Pani, pani, pani. So we go again. Now the polyp is removed. Okay, you see that? There's no polyp anymore. So this is one tubal ostia. You see the depth and other tubal ostia, right? So my reference is this point and gently. It's not a short septum, it's a big septum. Huh? Tubal ostium here, you see how much distance? It's a long septum, not a short septum. And calibrate, still little part. You see very gently and bite by bite, very gently. And that's enough, this side enough, right? And now you see how much cut of the septum, the other side. Tubal ostium is your landmark. You see it? And enough here. This part is enough. In the middle, we have to cut more. Very gently and very carefully. You see how much of the septum, Dr. Jidip? Now we go to the central part and carefully cut. And now we look at that. And like the tailor or like the hairdresser adjusting the haircut, I calibrate still some more here. Enough. This is enough here. And then the other side also little cut. So this is the tubal ostium. And that's the final view. Nothing. Nothing. Let me check something. Let Dr. Malhotra to do for her. This is a myoma. You see that? Oh my God. Oh my God. Put the loop again. You are not seeing the myoma. I will check. I will just take one bite and see. Are you afraid? Okay, you can do ultrasound for her, but I'm sure this is a myoma and it's submucous. So when the septum heals, We can do little test. We'll take one bite and check if it's a myoma or not. And that proves that septum is myometrium. In the private, when I have case like this, Yahya is my son. He is a better businessman than me. Dad, don't touch the myoma. I say, why? No, let her go home, do an ultrasound. She'll come back and she'll pay another fees. Okay, don't do. No, Yahya is absolutely business mind. We will do little test. $250. Pull up. 250. Start. Power. So we have to clean first, to clean. This is my suspicion that this is a myoma. So what I will do is take this one. The film is not working. This piece, you see that? The thermi is not connected. Already connected. Why it's not working? Are you ready? No, it's not cutting. This is a myoma, right? I am sure this is a myoma.
Definitely require a second look.
Sure. When you have multiple procedure, if the myoma is in a different place than the septum, I would not remove it, because if you have two opposing scars, that will make adhesion, myoma and septum. Even we just do the test, so you can convince her to come next time to remove the myoma. And the myoma would be very easy. Naharika can do it. It's a small size. And after healing, it will bulge more. It will be more easy. You were doing fine all the day. What happened to you now? What happened to you now? Clean the electrode always. Okay. Hold this. Pani. Every time you go in, we have to clean. Okay. So the cavity starts to collapse because of the, I'll take only one strip. No. No. I will not waste more time, because if the endometrium starts to swell like this, I will prove it to you it's a myoma, Dr. Malhotra. Keep looking. And then when I close this, you see the bulge? You see the bulge? You see that? This is bulge, okay? This is like about 2 centimeters fibroid. And after healing, it will be easy, yes. Okay. Now, no. Because if we take much more time with water, will not be safe for her. Yeah. The scan shows anything?
More of like look at more adenomyoma.
Maybe. But whether this or that, she will benefit or not. Why I stopped continuous surgery, you have to learn this. You notice now the endometrium starts to swell, because after I remove the septum, there's an open space. So the fluid goes underneath and the endometrium will be swelling, absorption will be more. So there is no need to compromise time.
Okay, great.
Please, can you give an applause to anesthesia team, the anesthesia team. What's your name, anesthesia?
New anesthetists come for first place.
Really? You don't deserve it. No.
You just come to make this.
But anyway, another applause for the OT staff of Rainbow Hospital. Yes, OT staff. Yes, good. Yes, take it, yes.
We'll finish, we'll close this live chat.
Thank you, sir.
Wonderful session today, but we have a few questions from our online attendees, and they're saying that can you inject pitracine at the bed of a fibroid before the surgery?
There are some studies in the literature that if you inject vasopressin, the same way we use the needle for PRP, you can inject vasopressin trans-cervical into the myometrium around the myoma. The advantage is not concerning the bleeding. Bleeding is not an issue, but it decreases the fluid absorption for the large myoma. So you can, exactly. So you can be more relaxed, taking much more time to do resection. Paracervical plop, I've never done it in my life. Only once in Pune. I was doing workshop, I was giving a lecture, not a workshop. And then after the lecture, people taking selfie, one doctor said, sir, can you visit my clinic? I have a clinic and I have a case of submucous fibroid. I love to work. So I said, definitely, let's go. Even I skipped lunch and I went, and I was shocked. It was not a clinic. It was not a, it was very humble apartment in a very humble building. And even there is no OT table. The patient is, and there is no legging. The patient hold her leg like this, like that. I said, okay, how can we operate? Where is the anesthesia? He said, no anesthesia. We use paracervical block. I told her, I've never done it in my life. I said, I will teach you. And then the patient was doing like this, and she gave paracervical block, and I did a fantastic myoma resection, and the patient was awake, you know, but I didn't repeat it again. I wouldn't be in the same situation, but paracervical block can be suitable for office procedure, which needs more time. Any question?
Last question, that how do you decide the site of injecting PRP?
There is no rules. Some people say only one site is in the fundus is enough. I do it empirically, 4 points, anterior, posterior, and lateral. Okay.
We also
Yes.
do like 4
Yes.
points.
And
We do 4 points. You saw us doing.
and in the literature, they say only half ml is enough. But I am generous. I give half. And if I have some more, after I do this injection, I flush the cavity by the remaining PRP. That's what you.
Thank you to all the online.
Yes, now we appreciate the online people. They are working from the morning to let you enjoy the show and very clear image.
So we're breaking for lunch and certification.
Okay, we go down. I collect my stuff.
We go down, basement.
You have to buy one like this because my computer will not work. Okay, ask him. No, this is more important. Which one? This cable.
This cable is available everywhere. This is important. This is mine.
Can we buy one?
Online. I will give you when you go back.
What? This one.
This is same everywhere. We get this everywhere. This is actually a mic. Yes. I have a collection of orders from you.